I mean, I at least screen for my adult patients. I'm talking about tuberculosis, and we find roughly about 30% of the patients have biopsy proven or other evidence of active tuberculosis, even though they are afebrile. So, I mean, it may vary from institution to institution, but screening does help, but again, it carries the burden of anti-tubercular therapy before you embark on the therapy with Ritux.
Okay, hi.
Yin Sensei here. I'm from the UK. Yeah, that's a very nice talk. We've been using rituximab for over 10 years now, and it's really good, and as you said, it's very effective. For children who've got steroid, who've got SRNS, who've been very difficult to control, but with tacrolimus they've done well. If you see toxicity on kidney biopsy, would you change them over, or would you keep them on tacrolimus despite a little bit of toxicity?
We would change them over. If we find toxicity on kidney biopsy, is that your question, that on kidney biopsy, if we find calcium inhibitor induced nephrotoxicity, would you want to change them over to a less toxic therapy? Yes. We would want to move on to either rituximab or MMF in that context.
Yes, I mean, I suppose the question is because tacrolimus is so good that if you change them over, you're likely to lose control. So actually, it's a balance of whether you keep them on something that works or you change them.
Excuse me, sir, you are not audible to the. Your questions are not audible.
Okay. So I think what he intends to ask is that you are, suppose you have a patient with steroid-resistant nephrotic syndrome who has entered disease remission with tacrolimus and he's doing well. And you rebiopsy and you find some evidence of toxicity. Would you want to, whatever? I mean, what do you call it? Rock the boat by giving rituximab and risking another relapse while getting him off tacrolimus or not. So usually the nephrotoxicity would emerge beyond 3 years or so of tacrolimus use, not earlier than that. And around that time, when we have used this strategy, if you were to look at the Kaplan-Meier's, I mean, we've done really, if you monitor the B cells and you give another dose and you give another dose, you stay off CNI as well as steroids in 90% of kids. The Kaplan-Meier's are that high for the relapse-free, so at 2 years. So I think once they are in remission, if you were to administer that, monitor B-cell depletion, look for repopulation, administer again, we have managed like that. But it's a difficult disease. You miss one dose of rituximab and the relapse comes back and it's back to resistance.
Only one question. Yes, Dr. Narayan.
Aditi, thanks.
Dr. Prasad also. Yeah, ma'am.
So you touched on hypogammaglobulinemia, but in the really difficult patients, when you want to redose them, but you are having a hypogammaglobulinemia, do you resort to gamma globulin infusions? And if yes, then how many doses and for how long?
I don't know whether we should be preaching to this audience all this, but I think we should not. We do what we have to do in anecdotal cases, one of balancing risks and benefits. We have had to do this on occasion. That we have given IVIG, we have waited 4 weeks for the immunoglobulin levels to climb up, but that's not what we should be telling that we should do.
Yeah.
Oh, Dr. Narayan. Dr.
We
Narayan,
have just one
that's
comment.
the last question which we are going to.
Yeah. So, rituximab, what our experience is, in none of the patient of the steroid-resistant nephrotic syndrome who was resistant to steroid plus CNI has responded in our series. Then steroid dependent, you have multiple options then. You have this CNI, tacrolimus, cyclosporin, mycophenolate mofetil, you are monitored with the AUC. And as far as concern of the CNI toxicity is concerned, sometimes you can just get by acute kidney injury is thought to be fine.
Yeah.
And that can be easily recognizable and you can reverse back, but you are maintaining in this dose, recommended dose, then that is also not the problem. Chronicity pupils of the use of the CNI toxicity do not believe too much. No. Because you can see the many patients of the renal transplant recipients are there on the 40 years, 50 years doing repeated biopsy, and this kind of the fibrosis which has been done in the 70s or 80s when cyclosporin came into the picture of the use, very high doses of the CNI causing this kind of the problem of the chronicity, interstitial fibrosis, tubular atrophy. Now people do not believe. But then comparison of the rituximab versus side effect profile, that remains important. Like PC at your institute,
Yes.
that patient has hypogamma making a lot of confusion for so many different
Kikuchi
kind
and
of
hypogamma, yeah.
so,
Yeah.
so that kind of complication, again, pupils have came, seen the zero count is making up CD19 count, again you are giving the rituximab, again it is coming down, again giving this. This is the too much of the toxicity for the patient. Do you still believe that we should use repeated use of this rituximab?
I think, you know, very often we take a patient perspective in picture, and I think all of us pediatric nephrologists have patients who want rituximab on their rituximab birthday. I mean, Dr. Srivastava has them, Dr. Shushmita ma'am has them, Anil has them. They are like, why don't you give him rituximab? He did so well on rituximab. We are like, please don't ask for more rituximab because we have had too many rituximab. That's how it often goes the other way. And the other example I'll give you, sir, is 2 years of COVID, we did not use rituximab, and we had so many CNI and AKIs. We had so many CNI nephrotoxicity on biopsies, which we had stopped doing biopsies for 10 years. Since 2013-14, we have not been doing biopsies for CNI toxicity. I mean, I think it's the experience for many of us. The third argument for rituximab is these kidneys need to last 15-20 years longer than the audience that you probably pander to. That's all that I would say. But I think, yeah.
So with this, we are concluding session. It was always very great to see so many interest and questions which are coming from the audience. And if there is any further questions, we can you can ask all these questions maybe later at the tea stall. And now we are ready for the next session. Thank you.
Before we move to the next session, I am sure all of you are looking towards. I request Dr. Sushmita to come to the dais because she has to make some announcements.
Thank you very much. I would take this opportunity to invite everybody, all pediatricians, all nephrologists from the East Zone particularly, to come and attend the Indian Society of Pediatric Nephrology conference, which will be the national conference, which will be held in Kolkata on 13th, 14th and 15th of October. This is a very important week for us because it's the week preceding Durga Puja. So the stars will be right, and I think we can give you a extremely good experience. On the 13th, we will have 3 workshops. They will be on nephrogenetics, on acute kidney injury, and on bladder and bowel management. So these will be small groups, hands-on, very intense workshops. And then the next 2 days, we will have 2 different tracks, one for nephrologists and one for general pediatricians. Our theme for this conference is from foundation to frontiers. So we will be covering the entire gamut of pediatric nephrology, from very simple basics like nephrotic syndrome, UTI, congenital anomalies, etc., to critical care nephrology, genetics, maybe gene therapy. So we would really aim to cover the whole gamut and make it a very interesting experience for everybody. For this conference, we have a discounted rate of registration. So I would request all of you to avail of this. Rajiv, do you have anything more to add? If you, there is a digi code, so if you scan that with your phone, you will be able to enter the registration site and to register online as well, if you would like to. Many of us from West Bengal and from Kolkata are present here. If you have any queries, we can try to answer them. So look forward to seeing you all in Kolkata in October. Thank you.
Thank you, Dr. Sushmita, for your important announcement. And now we are going to hear about journey of nephrotic syndrome in last 50 years. And I think you all would agree that we will feel blessed that we are going to hear someone whose books we all had been reading, and we consider him as a Bhisma Pitama of pediatric nephrology. So we are very glad to welcome Dr. R.N. Srivastava sir to the dais to deliver his lecture. And for that, we have chairpersons, Dr. Jai Prakash, who is consultant nephrologist at Panisha Hospital, Kabir Nagar, Varanasi, and Lifeline Super Specialty Hospital, Varanasi. We have Dr. Harshvardhan from our state, who is Assistant Professor of Nephrology at Patna Medical College. We have Dr. Gyan Prakash, who is consultant at Ford Hospital, Patna, Bihar. And we have Dr. P.S. Patel, Assistant Professor at IGMS Patna. So I welcome all the chairpersons, and I feel glad to welcome our speaker. And I request our chairpersons to introduce our speaker. Thank you.
It is a matter of honor for me to introduce the Professor Srivastava. In fact, he needs no introduction. Some of you may not know it. I just want to share two important points on his personality. Professor Srivastava initiated pediatric nephrology at All India Institute of Medical Sciences. In fact, he is one of the pioneer members to start pediatric nephrology services in this country. Dr. Srivastava is a very humble person. I remember Indian Society of Nephrology conferred on him Lifetime Achievement Award in 2011. At that time he said, I got the Nobel Prize. That was his expression. So you can imagine how humble he is. And his topic of keynote address is nephrotic syndrome over last 5 decades. I am also eager to hear his lecture, so don't want to come in between. I humbly request Professor Srivastava to go with his oration. Thank you, Professor Srivastava. Over to you now.
Thank you, sir. I have your autograph on my award certificate. What I'll do is to you all know nephrotic syndrome is a very common condition, and most of us spend nearly half of our time in treating nephrotic syndrome, either in practice or in hospitals. There is an early history here. Okay. Yeah, it was reported long time back, mostly adults, and the condition, the MS sarca, was noted. It was suspected to be cardiac or renal or hepatic. But in 1484, Rollins in Belgium described 54 children with swelling of the whole body, but there was no mention of kidney. 1722, Zingenball, its second description of NSARCA, but urine was not tested, not reported. We all know about the Bright and Bright disease, 1822. In 1905, Miller and Monk defined nephrosis as we know it now, and there was a lot of debate whether it was nephrosis versus nephritis, degenerative versus proliferative, inflammatory. Now we knew in 1950s that there were a small number of children who had the secondary condition, but it's mostly idiopathic. Then a very definite report in 1950 by Barnes Small in Janway, some of us pediatricians will be knowing about Janway. They called it lipoid nephrosis. And then early in 1961, again, he called it lipoid nephrosis. And the reason was that on the cut surface, the kidneys were large and pale, and there were lipids in the tubular cells. But there were similar features in many other conditions. So they decided to term it nephrotic syndrome. Initially, the focused on the management of 60s, 50s and 60s. It was a chronic recurrent condition, very difficult to treat, and the drugs were not effective. So they provided nutrition, tried to control edema. Now diuretics were simply not available. They tried xanthine derivatives, acetazolamide. We even tried mercurial. I remember myself trying mercury chloride, something very effective, but will knock the kidney out as well. chlorothiazide, alactone in late 1950s, these were not very effective. There were a repeated paracentesis, all kinds of manipulation. It's only when Lasix came in 1962, then we were effectively able to control edema. Outcome, before 1940s, the mortality rate of 40%, and this was mostly for infections like peritonitis, pneumonia, cellulitis, also thrombosis. Penicillin came in 1944, and then the mortality decreased to about 16%. And when they introduced corticosteroids, it further fell down to about 3 to 7%. And even at that time, we know that many of the, well, a small number progressed to chronic disease. They even tried ACTH by Metcalfe Janeway in this dose. It seems to lead to diuresis and even some reduction of proteinuria, but it was considered hazardous and not used further. Now, cortisone and prednisolone, of course, they caused abolition of proteinuria and clinical benefits. Different regimens were used, but it was like a magic drug. I mean, the way the child responded was really something magical about it. Majority responded, but again, there is a long-term clinical course. They lumped all cases together, but even so, the majority seemed to respond. The renal biopsy was not carried out then, so it was very much a clinical situation. The biopsy was introduced only in 1951. Versen and Brun 1951, the biopsies, aspiration biopsies in adults are a very few conditions. Using the Wilm silver and needle with modification, the kidneys were localized with plain X-ray film, mainly to make certain that there were 2 kidneys were present. Of course, ultrasound was not available. There were very few serious complications. There was a series of reports from our own training center, UTM Galveston, from 1962 to 76. There was a lot of apprehension in the pediatrician at that time that it will be hazardous to do it. So in our center here, some of us reviewed 890 biopsy consecutively done, the large number. We were doing biopsy left and right, but there was few serious complications, hematuria of course, but we didn't lose a kidney. So it was followed by widely adopted. A big landmark which many will be familiar with, the International Study for Kidney Disease in Children, ISKDC. This really was a big multilateral, multinational study on those times, starting in 1966. They studied clinico-pathological correlations and treatment trials in 521 patients between 1966 1974. There were 24 centers in Europe, Japan, Mexico, and so on, and large number of patients from England, Japan, Finland, our own center, and all biopsies had light, immunofluorescence, and EM examination. Talking 1960, those times, so early on. And all biopsies were seen by 3 experts without knowing the details. And these were Dr. Chur from USA, Dr. White, UK, and Madam Habib from France. Our own people will be familiar with these names. I'm showing this picture, this is 1966 in London. The first meeting of the group, I show particularly my own mentors, Luther Travis here, Dr. Drefner, Madam Habib here, Gavin Arnell, Ira Greifer. These are the big names, all big names at that time. A picture 20 years later, this is a Japan meeting, Kamakura. They have gone much older, Dr. Arnell here, and somebody here. And anybody can guess, adult nephrologist, Stuart Cameron. You heard his name? I'm sure you heard. The big names on those times, this is 70s. Now the major contributions of ISKDC were they defined the histological features very lucidly. Description of FSGs, mesangial proliferative, membranous proliferative, and so on. Features of minimal change disease, 77% were in the patients, and the clinical correlates. And the response to treatment, corticosteroids, and actually even they study cyclophosphamide later on. Now, the initial regimen they used was prednisolone, 60 mg per meter square per day, 4 week, we all know this. And this schedule was empirical. There wasn't any trial, no evidence like that, but even so, this schedule were followed by most centers for the next 20, 30 years. The result was that you could compare the findings in many centers, and most centers around the world followed this. The observations were nearly identical. This is showing the response. It's just like magic, I mean, the majority of children, the first week, second week, third week, about 80-90% patients respond within a month. A few take a bit longer. This was something extremely interesting. Now, this was followed for some number of years. Then only the German study group, 1993, they described, this was discussed by Dr. Sushmita here, that using 6 week daily, 6 alternate day may lead to a better outcome. And this was confirmed in several studies now. This is the guidelines for many of these groups. The recent trial, UK saying the 4 week may be sufficient. So we have a choice now to either use 6+6 or 4+4. The global pattern of idiopathic nephrotic syndrome, it seems to be very homogeneous. Age, sex, response outcome-wise. Studies from UK, France, Japan, Australia, India, our own study reported almost similar findings. The incidence, the age pattern, and the response. The incidence of FSGS, mesangial proliferative, this was also comparable. Again, 75 to 80% have minimal change, are still responsive. So this is no longer called as a minimal change, simply called SSNS, steroid sustained nephrotic syndrome. The long-term course is punctuated by relapses, but eventually most get complete recovery. Briefly, steroid-resistant nephrotic syndrome, they have defined how to label these. I think we are doing that now. Many patients have FSGS, and in those times, talking of 70s early, the cyclophosphamide was used in these patients and found to be effective in a good number of patients. And that was the only drug at that time, mind you. And it was widely used, but later on given up. But there was a small number of patients who had late resistance. And there was a lot of discussion whether it was a minimal change to begin with, and it sort of morphed into FSGS. And it was even suggested all these conditions, they form a spectrum at one end minimal change, other end all kinds of things. This was intensely debated during 1980s. I don't know what you feel about it now. Treatment of nephrotic syndrome relapses, this has been discussed by previous speakers. Again, the endoxin was the only drug for about 20 years, and the usage for 2.5 mg per kg, 8 to 12 weeks, led to long remission. And some of the drug, like, almost a cure in some patients. And the benefits have been confirmed, but of course, there are better drugs now. In the beginning, they tried NSAIDs, but these were not effective but toxic. Levamisole came much later, and you have been listening to all the drugs besides steroid. They call it steroid sparing. To my mind, this is a total misnomer. To call them steroid sparing is like insulting these drugs. You talked about rituximab and all that. Now this is very interesting. The mechanism of proteinuria was intensely studied in 70s and 80s. We know about endothelium, basement membrane, epithelial cell and so on, the food process and so on, and the effacement of food processes were seen early. Now this is again a picture showing the normal EM here and the minimal change, the effacement here. Now this, on those times, was something extraordinary. I mean, you couldn't believe all this. but it was there, shown very, very clearly. A lot of studies on the composition of the GBM, structure and all that listed here. Extensive work in 1970s, 1980s. Now, filtration of proteins are very, very incisively studied. Filtration depends upon size and shape and charge of proteins. High molecular weight proteins and those with anionic charge, they do not penetrate lamina densa. There were clearance studies using tracers, different sizes and different charge, and this was very clearly shown. Very elegant study. If somebody is interested, it will be worth looking at. Now, this is a frightening slide, but very simple actually. The capillary lumen here, the GBM here, the urine space here, and the anionic charge molecules here, the neutral here, and the cationic here. Is really the tracer different sites, ferritin, catalase, albumin, horseradish peroxidase, and so on here. These, the large molecule, they do not penetrate. And here, the neutral one, the smaller ones, they will penetrate, but large ones don't. The cationic proteins, the small size easily penetrate. Even the large ones with cationic, so they can penetrate. This is really from 1970s onwards. Dr. Venkatstalam, one of the leading workers here, worked with us in AIM for some time, then he left. Anyhow, then there was a lot of discussion about the polyanionic charge, and decrease in the staining for polyanionic coat epithelium in the GBM was shown in congenital nephrotic syndrome and also in the pyromycin-induced proteinuria. The GBM was regarded as the main filtration barrier. This is like 1980s, but probably not proven to be causally related to childhood nephrotic syndrome. Then there were some studies again in 1970s, 80s measuring the size of the molecule. So they measured the protein clearances of different molecules, and they thought, well, this minimal change nephrotic mostly albumin, and finding that could differentiate between the others, but there was a lot of overlap, and this was sort of given up. The pathogenesis or minimal change nephrotic syndrome, we discussed about the immunological changes, the measles and all that, you mentioned that, and a lot of work on the T cell subsets, different kind, but there's no uniform pattern. Doctor mentioned about the circulating factors. Lymphocytotoxin, there was a vascular permeability factor 1975, lymphocyte inhibitor plasma, these were of historical interest. Findings were inconsistent and inconclusive. And more recently also, Dr. Aditi will tell about the SUPAR and so on, but there is no clear pattern diagnostically. In the 1990s, there was a slight interest in what they call reactive oxygen metabolites. These sort of come into fashion. At that time, for about 7 or 8 years, a lot of studies came in different conditions. And they were thought to be injurious to cell membrane, cell components, and membrane lipids. And lipid peroxidation could be detected by measurement of malondialdehyde in the urine. And pyromycin aminonucleoside-induced proteinuria is the most reproducible model of minimal change nephrotic syndrome, and this can be prevented by administration of free radical scavenger like dimethylthiourea. Our own study here, we studied in 3 groups of rats, one control, other given pyromycin, other given pyromycin plus DMTA, and shown clearly that the ones who had DMTA, they had little proteinuria, very little proteinuria. And we may have actually measured the glomerular and malondialdehyde and DMTA. But of course, this is out of fashion now. If somebody has to waste time. You can look at this paper somewhere. Now, this is the era of podocytes and genetics, as you have heard a lot about that. Study of podocyte structure, mechanism of injury and repair, genetic abnormalities, and so on. The podocyte injury is involved in everything now. Then everything is working through modification of podocyte structure and function. It probably is not as simple as that, but as Dr. had mentioned, it will take many years now to translate this into clinical effect or even understanding. Now, steroid-sensitive nephrotic syndrome remains an enigma. Advances in genetics immunology have not led to identifying the etiology, and the regimen, are, despite guidelines and everything, but the initial regimen, I hope don't fight with me on later, and subsequent management is still debated. The guidelines, are they globally applicable or they local modifiers? We don't know, at least I don't. The SSNS can be managed successfully and serious complications avoided until the condition remits permanently. That is being done for the last 60 years. Questions are, what initiates podocyte injury that leads to massive proteinuria? Circulating factors are likely but remain elusive. And the mechanism of action of agents, including all these, do they act similarly at that one point that abolish proteinuria and restore podocyte architecture and function? It's unknown. And what causes relapse? They talk about viruses and EB virus and all that, but not defined still, I think, it'll take some time. And what are the changes taking place, what takes place during the relapse? Oh, 3 times it's up. It's up anyhow, I know that. Show my last slide. Last slide दिखा दो मेरे भाई. नहीं चल रहा? बिजली काट दी क्या? नहीं आ रही भाई, कोई बात नहीं. लास्ट स्लाइड नहीं आ रही? आप चला दो. है लास्ट स्लाइड है? नहीं छोड़ दो. Leave it.
You can continue, sir.
I think the slide is missing probably. Oh, thank you very much. That's all. It is actually all the historical interest, but nevertheless, I think that's how things have developed. You take any disease, any condition, that's the way it has come up. Nothing has come in the bang. And when you read this, you really feel how intensely these people, they were not dumb people, they were brilliant people. We met some of them. They're highly intelligent people and doing all this. Now, this may not be relevant, but that's it. That's our history. Thank you.
Thank you, sir, for an excellent talk. And we can definitely take on few questions or comments. Okay. So let's a round of applause and standing ovation to
Thank you very much. It was interesting to see the early parts when you were developing the biopsy, left and right. We don't do that now. You were doing biopsy in post-septicoccal nephritis and so on, but that's how we learned. Thank you very much.
Thank you, sir. Thank you.
After a plenary session by none other than legendary Dr. R.N. Srivastava, I think most of us have tea, so we'll skip that tea break and we'll continue with our second session. The first session, as we all know, it's on nephrotic syndrome, the unasked questions. Now moving to second session, that is on mixed bag. And the first lecture on this session is on revival and survival of CAPD in children. For that, I would like to invite Dr. Sanjay Gupta, who is Senior Consultant Nephrologist at Bhopal, Dr. Amresh Krishna, who is Additional Professor, Department of Nephrology at IGIMS, Patna, Dr. Deepti RV, she is Associate Professor at Division of Pediatric Nephrology, Department of Child Health, CMC Vellore, and Dr. Santosh Kumar, who is Consultant Nephrologist and Renal Transplant Physician at Paras Hospital, Patna, to chair the session. May I request Chairperson to introduce the speakers? And I'll request all the audience to please keep the silence so that this session will go smoothly. Thank you.
Good evening. All have now listened to various topics of nephrotic syndrome and their treatment. Now we go ahead in the pediatric population, the most difficult task to deal with, and that is the chronic renal failure and ESRD. So technically, very highly demanding hemodialysis cannot be performed in these patients, and they don't do as well as the peritoneal dialysis, which remains the only alternative to treat these patients. We would be interested in knowing about the continuous ambulatory peritoneal dialysis, which is nowadays very much prevalent for pediatric age group of patients.
Where is the mouse?
Dr. Georgie Abraham has pioneered the CAPD in India, and he has been trained with Oriopolis in Canada, who actually invented this technique. He's a professor and consultant, MGM Healthcare Chennai, adjunct professor IIT Madras, president ISOT, founder president PDSI, trustee of Tanker Foundation, 342 publications and 266 abstracts in his bag, 33 book chapters, 3 nephropathology CDS, and recipient of many regional and international awards from NKF America, ISN President Sri Lanka, and Federation of RCP UK. So without taking much time, I invite Professor Georgie Abraham to speak upon this technology of CAPD in pediatric CRF patients.
At the outset, I want to thank Professor Hemant Kumar, Dr. Kumar, and the organizing committee for giving me this opportunity. I love this theme, children and kidney disease. Suffice to say that with over 30 million pregnancies in this country every year, we have a lot of children, and we face the challenge of kidney disease in these children, either acute or chronic. The treatment is predominantly either dialysis, transplant, or palliative care. And I would take you through this presentation, what I have done, my experience, and also the experience of my colleagues. So any renal replacement therapy, the most important thing are the cost, the quality, and the accessibility. It is sad to say that even though we have progressed over the last 30 years, the accessibility to flexible or bags which are aseptic and safe for children are not available in the country in half-liter and 1-liter bags. The appropriate catheters are not available. So there is a question of accessibility. Cost, the PMJAY scheme, I also put a recommendation through the ICMR, and it was very nice that the Prime Minister Modi ji has included it in the PMJAY scheme. And the quality, there are issues with regard to the quality, especially the dialysis fluid. And I have noticed, I'm sorry to state that some of the manufacturers, they have inferior quality fluid, which is leading to a lot of peritonitis. And this I have spoken to them, but it is falling in deaf ears. So essentials of a PD program are, evaluation and selection of patients for PD modality options, evaluation and management of medical complications in patients on PD, understanding principles and practice of PD, choosing appropriate catheters, dialysis fluid in small collapsible bags, long-term follow-up, dialysis prescription, modification and assessment of dialysis adequacy, and use of automated PD. This is the first child we started nearly 30 years ago on peritoneal dialysis. This was Kirti, 1.5 years old, referred to me by Dr. Fatke from Bangalore. And I am the one who is holding the kid. I just want to bring you to your notice that when William Kolff started the hemodialysis, the first 15 patients died. He never gave up. So even though many of the children died, not being able to access, and I am happy that over the last 30 years, with the support of my dearest colleagues who are sitting here, both in pediatrics and in adult nephrology and pediatrician, we have been able to achieve many things. And seeing this photo, it was published all over the country, and Press Trust of India, Professor Srivastava is not here, an incredibly fantastic role model he is. And he gave me in a meeting a few months later when I was in Delhi, Georgie, you have done something good, encourage me. That is the positive attitude of a person who wants to support the country and the people in this country. And recently he was felicitated by Arvind Kejriwal, and for his multitasking achievement he has given to the country. And also he has been given a Lifetime Achievement Award by IPNA in 2022. So advantages of PD are fewer side effects compared to hemodialysis, no needle-free treatment, do not have to travel to dialysis center for treatment, greater flexibility and freedom in the treatment schedule, can do dialysis while sleeping, and allows travel and allows children to go to school, and also in engaging sports. I will skip that. So what are the absolute requirements for peritoneal dialysis? You need a healthy peritoneum, which should have enough surface area, and it should have hydraulic permeability, and there should be osmotic agent, which is provided through the dialysis fluid. Then these dialysis fluids should be in sterile collapsible bags and a permanent and safe access to the peritoneal cavity using a permanent catheter. So when you look at that, you can see you have the capillaries here, you have the interstitium and the mesothelium and the peritoneal cavity. So you have three types of pores. The first one are the aquaporin pores, which are intracellular, and then you have the intercellular pores and the large pores. The aquaporin pores and the intercellular pores are responsible for the water removal because of the hydraulic permeability and also because of the osmotic agent in the peritoneal dialysis fluid. So if there is a problem with aquaporins, then you may have to use, I have a patient recently, you have to use predominantly icodextrin. So these are the three important components of peritoneal dialysis. Excuse me. Yeah, got it. So I wouldn't go in detail into the blood circulation in the peritoneum, but what is peritoneum? The peritoneum has two layers, the parietal layer and the visceral layer. And the parietal layer is the one which is responsible for peritoneal dialysis. And you also have the blood vessels there. And as you see that the blood vessels are here seen in the peritoneal in this cartoon. And this has to pass the solute and the water has to pass this distance to reach the peritoneal cavity. And these are the mesothelial cells. So the peritoneum is a serosal membrane that covers the peritoneal cavity, the visceral and parietal peritoneum. Role of peritoneum is to protect peritoneal organs, prevent friction of moving organs, and host defense mechanisms such as mesothelial cells, macrophages, and immunoglobulins. So when you implant a catheter, it is very important. We don't have suitable catheters for children available all the time in the country. I'm sorry about this complex cartoon, but when you put a catheter, if you are going through the rectus muscle, you should always avoid injuring the inferior epigastric artery, especially when you do a blind procedure. Well, this is how a catheter looks like in the cartoon. This is the outer cuff. This is the inner cuff, which sits on the muscle or the linea alba. So what are the types of catheters? And preferred are a Swannock catheter. I use Swannock because I have used all types of catheters in the last 34 years, but Swannock catheters are the ideal catheters for adult and pediatric peritoneum. And this is a catheter which we have given to, because we make our own catheters, but it is stopped for the time being, and it is being implanted by Dr. Arpana Iyengar and her colleagues in Bangalore. So peritoneal membrane and anatomy, it's a serosal membrane with an area of equivalent to body surface area. 80% is visceral peritoneum, and it gets its vascular supply through the mesenteric arteries and the portal veins. 20% is parietal peritoneum and gets its vascular supply through the arteries and veins of the abdominal wall. Lymphatic drainage of peritoneal cavity is mainly through diaphragmatic stomata. It is a semi-permeable bidirectional membrane continuous with the fallopian tubes in female. So sorry about this busy. So this is the peritoneum again. You have the basement membrane, you have the mesothelial cell. This is the interstitium with the blood vessels. And the 3-pore model. And this is how you prepare for the peritoneal dialysis exchange in a child. You need to take aseptic precautions with mask, clamps, and these are the catheters which we manufacture in Coimbatore, much cheaper than the one you import. And this is the insertion set which we manufacture. So looking at this cartoon, you can have problems anywhere from the dialysis bag, the Y set, the adapter, the catheter, catheter cuffs, exit site, catheter tunnel, and peritoneal cavity and bowel. So the composition of the peritoneal dialysis solution, because we know that it is an osmotically derived solute and water removal. So the osmolality between the 1.5% is about 345, and that of the 2.5% is 395, and 4.25 is 484, but that of icotextrin is 282 because they are large molecules. So terminologies are in peritoneal dialysis are ultrafiltration, a reflection coefficient for most osmotic agent. The glucose has a reflection coefficient of 0.03, so it gets absorbed, whereas the reflection coefficient of icotextrin is 0.7 to 1, so it doesn't get absorbed. Sieving occurs, and this is another property which is important in peritoneal dialysis. So the principles of ultrafiltration are net ultrafiltration equal the volume collected in the and minus the volume installed and the duration of the dialysis dwell. So this is the peritoneal equilibration test which we do 1 month after the initiation of PD. It shouldn't be done prior to that because the peritoneal membrane characteristics may change. So in child it is 1100 cc per meter square body surface area. There are different studies which are published, but it is an individual property of the kinetics of the peritoneal cavity and the peritoneal membrane. So what happens with the solute removal during COPD dwell? Diffusion is maximal, and so urea and creatinine equilibration are fastest in the first hour but become slower as the gradient lessens with time. By 4 hours, urea is over 90% and creatinine over 65% equilibrated in most patients. Dialysate to plasma or D by P ratios measure degrees of equilibration at a given dwell time, and so it could be usually a peritoneal equilibration test. You have it at the end of 4 hours, and they are classified into low, low average, high average, and high. This is depending on the D by P of creatinine, and the drain volume also will vary. In low they have very high drain volume, whereas in high it is low drain volume. So framework for PD eligibility: incident ESRD patient, children or adult, peritoneal PD candidates, eligible for PD, contraindications to PD, medical or social, you have to look at it, and barriers to self-care in PD. Then patient start PD in 6 stages: new PD patient, identify, assess, eligible, patient chooses PD, PD catheter implantation, PD start, time on PD, and loss of PD patients. So the loss is either due to technique failure, death on PD, transplantation, or transfer out of the region. So this is PD in children. Dialysis inflow volume is 1100 cc per meter square or 30 to 50 cc per kilogram per exchange. the child is holding the transfer set. This I downloaded. This is not my patient. I downloaded from the internet. So all vaccinations should be given. I know pediatricians are quite familiar with that. Adult nephrologists are naive about it. So I just copied it. And so all vaccinations should be given. So peritonitis in children, I need to acknowledge Sushmita. She wrote this article in Indian Journal of Peritoneal. I'm sorry that I didn't put your name there. So prevention is use of Y-connecting system, systemic antibiotics given within 60 minutes before catheter insertion, daily antibiotic application to exit site, prompt and effective treatment of exit site infection and tunnel infection, antifungal prophylaxis with antibiotic therapy, training by qualified staff, testing skills of a person, and institutional continued quality improvement. So this busy slide, anemia and growth retardation in children on chronic peritoneal dialysis, malnutrition due to decreased nutrient intake, then increased nutrient losses through dialysis fluid, then increased nutrient requirement when there is peritonitis, and the risk factors for growth retardation in children with CKD are malnutrition, age of onset of CKD, underlying renal disease, use of corticosteroids, residual renal function, water and electrolyte disturbances, syndrome associated with CKD, metabolic acidosis, anemia, and hormonal imbalance due to growth hormone, gonadotrophins, parathyroid hormone. So this is recombinant human. I have used it in one of my girls, 0.3 milligram per kilogram per week on 3 alternative days, 3 times, 6 times. And these are the nutrient requirements, infant, pre-puberty, puberty, and post-puberty. And the calories are shown here, and the protein requirements are shown there. And 50% of the dietary intake should be fat, and carbohydrates 35% of the dietary intake, and you need all the B-complex vitamins to be supplemented. So the complications are infections or non-infectious. This can happen both in adults and children, and so we need to look at that and carefully evaluate for this. So routes of infections in PD are exit site infection, tunnel infection, contamination, migration from the gut and vagina, and septicemia. So local and systemic effects of PD, long time, high glucose PD solutions, the local effects, high glucose injury to the peritoneum. Then systemic effects are shown in 10% of adult patients on PD will become diabetic in 1 year. Then peritoneal membrane changes are shown here, and the patient malnutrition, obesity, inflammation, atherosclerosis, fluid overload, and metabolic alterations. So this is a paper from St. John's, and when you look at duration of CPD, change in BMI, change in height, centile, prevalence of short stature, residual renal function, PD adequacy, and peritonitis rate between those below the age of below the 15 kilograms and above 15 kilograms. The only thing we showed a little statistical significance is prevalence of short stature. So when it was a structured audiovisual training in the same institution for caregivers of children on chronic ambulatory peritoneal dialysis, a prospective study of the impact on the rate of peritonitis, structural training program in 40 compared to regular training program, you can see that there is a significant difference in the survival functions. This is the survival function over a period of time. Those cohort group who had structured training program did better than the regular group. And even in peritonitis rate also, you can see that there was a significant, statistically significant difference compared to the structured group and the control group. So peritonitis is diagnosed in presence of any of the following criteria: abdominal pain or fever, cloudy peritoneal effluent with over 100 cells per cubic millimeter with greater than 50% polymorphonuclear cells, demonstration of organism in the PD fluid by smear. So this is a bag before infusion, this is after infusion, after drainage, and this is a cloudy bag. So peritonitis take-home message: patient and caretaker education, proper specimen collection and culture techniques to reduce culture negatives, identify and treat peritonitis at the earliest, establish your own center-specific microbial and antibiotic sensitivity data. Do not hesitate to remove the catheter microbiologists to be sensitized regarding COPD and peritonitis. Optimizing outcomes, infection. There are also been a dramatic reduction in the exit site infection with use of topical antibiotics at the catheter exit site, mupirocin or gentamicin ointment. There has been a dramatic reduction in peritonitis in recent decades, but we are still not yet there. So this is another one on peritonitis from the same number 38 during the pandemic phase and 43 non-pandemic. And they found that during the pandemic, there was a very high incidence of peritonitis in this particular institute. So this is one of our patients with mitochondrial disease child, and there was catheter erosion, see that. And so we were worried what to do with that. Usually you will remove the catheter. No, we can relocate the catheter. See, the catheter was on this side, we closed it in, and we relocated without removing the catheter to the other side, and the patient continued on peritoneal dialysis. So management of children with peritoneal dialysis, growth failure, development, nutrition, hyponatremia, hypophosphatemia, poor ultrafiltration, infectious complications, hypogammaglobulinemia, mortality, dialysis consideration, and transplantation. This is another one, a child with bilateral ureterostomy. We did peritoneal dialysis. Later on, after 2 years later, he lost his mother in front of him. They were going in a motorcycle. The mother was killed instantaneously. The child went into depression. He had Pseudomonas peritonitis, and we lost him. This is the peritoneal biopsy of that child. And this is another child, see that. You want to have a standard child, and this is another one which we are doing peritoneal dialysis currently with severe heart failure. Hemodialysis, he wouldn't have survived. In between, we had to put in a jugular line to remove the fluid because he went into fluid overload. So conclusion, COPD and APD are two modalities of RRT in children. Nutritional advice and growth monitoring are important. Prevention and treatment of peritonitis should be center-specific. Anemia correction and CV monitoring is essential. Mineral-borne disease should be assessed periodically. Target for adequacy dialysis should be followed. Thank you for your kind attention. Thank you.
Thank you for the excellent overview, sir. It's open for discussion now.
Sharma.
In the field of peritoneal dialysis, and I don't know what is your experience. Like when I was in SDPGI, the PD really picked up. Despite patients had to pay for it, it was not a free treatment. But in the corporate sector, PD is a very neglected therapy because of so many reasons. The other interesting thing in PD, I think pediatric patients can be managed best with the PD because of so many reasons. But when we were having a very active PD program, and majority of patients were adults, the pediatric patient number was not that significant. And what has bothered me in India is that children with nephrotic syndrome would be taken care of, but children with chronic kidney disease, and especially when they have advanced renal failure, the way they are treated, because of so many reasons, they are actually to some extent neglected because of the cost, because we feel that they are not going to be the earning members. Then the question comes how long they would survive. When it comes comparing a child versus a young person or a male, even females are not treated so well. So I think there is a discrimination in that regard. But I fully agree with you that the pediatric population, when they develop advanced kidney disease and need dialysis, they would be better off on PD as compared to on hemodialysis.
I concur with you fully with that. I'm sure my pediatric nephrologists and colleagues, including Anil, is sitting there and smiling, because Anil was making a comment while we were going to the pediatric kidney transplant patients, especially those with CACT. They do not do well at all, because even though we transplant them, some of them do very well. And Anil, I want you to make that comment which you told me. Mike, please use the microphone. Right. Right.
When we analyzed the data, we found that, that they do well initially, but somehow after 10 years, the survival rate seems to significantly drop. And the only difference we found was in the number of incidents of UTI. They tend to have more UTI, but the rejection rates and all that, surgical outcomes are all similar. So we were wondering what is that where we are missing, especially in the long-term management of these patients. And an important point from the CAPD perspective is the ethical challenges that we have, especially when we are dialyzing somebody like newborn or early infancy, because it's a burnout of these caregivers that bothers us, and we finally end up thinking, what are we doing in these group of patients?
Sir, just one question that we in pediatric nephrology, we are still not getting 1 liter back.
That's what I am telling. I have been hitting on a rock for the last 30 years to the vendors to produce bags which are 500 cc and 1 liter, and that has never happened.
And what I understand from my interaction with Baxter, it will never happen.
30 years back, Baxter came to India because of me. And from the day they came to India, in 1991, I have been talking to them. Nothing happened.
Mitra has come up.
I don't know whether they have,
but it is not easily available.
So in the same context, and given the meeting that it is, can there be a joint ISN and ISPN written document to the companies like Fresenius, Baxter to provide pediatric consumables in the country? We all struggle in procuring hemodialysis catheters, filters, plasma filters, perm cats of appropriate sizes, PD accessories and everything. If there's a joint statement, because ISPN is a small society, if it's a joint statement, it would have a better impact.
Definitely, we have to pursue. Without pursuing anything, nothing works out. Narayana.
Yeah. Just in response to Dr. Aditi, this is all business. Yeah. So there was one liter bag available there, and so we have not to write to the companies. What we have to write to the government? There should be a quite subsidy on all these, because 18% then add on the tax, GST, making it too costlier. And I have talked in depth with this Baxter people. They have just calculated everything and have shown me each bag they are selling at our center at 10 rupees deficient cost. So they are not, even it was very difficult for last month to get the regular supply of the PD fluid. So this is always important, and we have to write to the government to get all these subsidies, make it off your GST, so that this can, at least this childhood bag, that is very important. Actually, sir, Permacath for the children, it was out of stock. It was out of stock. We have got 3 from somewhere from this corner of the Rajasthan. They have came with this, only 3 are available. That I understand. But we have to request to the pharma as well as we have to write to the government. Yeah, definitely joint statement always has some weight. We are ready to do that. Thank you.
And conclude the session.
Thank you,
sir.
Thank you.
So moving ahead, we have next session on approach to a child with suspected tubular disorder. For that session, may I request Dr. Arga Majumdar, who is Director and Head Department of Nephrology, Ambri Hospital, Calcutta. Dr. Sujit Kumar Sinha, who is a Senior Consultant Pediatrician from Patna. Dr. Abhishek Kumar, who is Consultant Nephrologist at Paras HMRI Hospital, Patna. and Dr. R.K. Jha, who is consultant nephrologist at Big Apollo Spectra Hospital, Patna, to chair the session. May I request chairperson to introduce the speaker.
Good evening and welcome to a very important session. Renal tubular disorders are often a cause of failure to thrive and growth retardation in children. And to talk on this very important topic, it's none other than Professor R.K. Sharma. He is the ex-head of the department and dean of SGPGI. And he has a particular interest in this subject, and it will be a pleasure to listen to him and how he approaches these diseases in children. Professor Sharma.
Good evening. Thank you, chairpersons, and thanks to the organizers, especially Dr. Hemant and Om, for organizing this combined meeting between pediatricians and adult nephrologists. My interest in renal tubular acidosis started when I was on a fellowship in USA and was working with many of the seniors might have heard Neil Kurtzman, and spent a year doing in vitro and other testing on rats and turtle. Turtle bladder is actually is a good model for acidification. You can use it to test acidification. And when I came back to India after the fellowship, I got into this clinical issue about the renal tubular acidosis. And as we know, just for the sake of the time, I am restricting to a subset of renal tubular acidosis in pediatric patients, which is quite interesting. And we did some longitudinal work in this area. And we know that the renal acid and base handling involves the bicarb secretion, bicarb absorption, ammonia production and secretion. And renal tubules are very important in terms of the hydrogen secretion. And there could be, because of the renal tubular acidification defects, our body homeostasis of acid-base milieu can get disturbed. And we have this set of disorders which could be as a result of the bicarb resorption being defective, or there is hydrogen secretion being affected, and ammonia production is also an important component. These are the classical types of renal tubular acidosis which all of us have learned. The type 1, type 2, type 3, and type 4. The type 1 is basically a disorder of hydrogen ion secretion by the renal tubules. And the type 2 is disorder of bicarb resorption. There is an excessive bicarb leak, and you can have a combination of hydrogen secretion and hydrogen resorption defects. And there are a set of disorders which we call as type 4 RTA, where it is the disorder of ammonia handling and aldosterone bioactivity. The spectrum is so large, and you can have different types of patients. We know that now there are a lot of genetic disorders with renal tubular defects. So the distal renal tubular acidosis, about which I would restrict this presentation,
is basically affecting the distal tubule and the CC, the cortical collecting duct, which can have hydrogen secretion, ammonia handling, and aldosterone bioactivity. All these occur at the distal tubular level. So they could all be affected, and you could get disorders resulting in hydrogen secretion defect, ammonia handling, and even aldosterone bioactivity. And it can result in a spectrum of renal tubular acidosis with different derangements being picked up. The other definition which you might be aware is translating the same defects into a so-called secretory defect, which is a classical distal RTA, where the hydrogen secretion is not being done as it should be by the distal coronary tubule, or there is a back leak which is occurring, which is called the gradient defect. These are definitions that are based about some of the testing techniques which were in vitro used to see how the tubule could be involved in acidification, and then the voltage defect, where the inability to generate a lumen negative transepithelial gradient, and as I mentioned about the ammonia and aldosterone bioactivity. Then we realized that there are special pumps which are there at the involved in the distal renal tubular acidosis, which are defective and producing the same gamut of defects which I have talked about. The hydrogen ATPase, the hydrogen potassium pump, and the sodium potassium exchanger getting defective, and a gradient defect. So all that, these pumps have been really characterized. Their structure has also been very well studied. So classically, these are the three defects which we talk about. The distal, which is basically decreased distal acidification, where you will find a urine pH which is not going down below 5.3, where you have diminished proximal bicarb reabsorption, the type 2 defects, you may find that the pH may go down below 5.3. So you may miss these patients if you're just depending on the urine pH. So you have to have a higher threshold to pick them up. The type 4, you may find a urine pH is less than 5.3. So urine pH is not an absolute way to rule out renal acidification defects. The plasma bicarb may also vary. The type 1 can have untreated much lower bicarb levels, while the type 4, the bicarb levels may be above 15, or type 2, you will find bicarbs which may actually be normal as well. In type 2, you will find, as we know classically, the fractional excretion of bicarb would be much higher. So the diagnosis of these different acidification defects will be based on clinical suspicion and then going through this gamut of tests to try to see if the body of the patient is able to acidify the urine. So you look at the blood pH. If blood pH is acidemic and you find the urine pH is more than 5.3, it gives you an idea that this patient has probably a distal renal tubular acidosis. But if the person is not acidemic, you have to induce acidemia, and that is why the classical ammonium chloride load test. If you suspect type 2, then you do the bicarb filtration test. The other classical clinical presentation which we have always been taught, that type 1 will have nephrocalcinosis or renal stones. Type 2 will have more of bone disease. Type 4 may not have any bone disease at all. So these I have already mentioned. We have patients who have partial distal renal tubular acidosis who may be totally missed by just looking at the conventional urinary findings of pH or the serum bicarb. So you have to suspect them, and then you have there the urinary PCO2 is one way to pick up these partial acidification defects once you have loaded these patients with bicarb, giving intravenous bicarbonate. These are the set of patients who may have aldosterone deficiency or insufficiency or bioactivity is affected. Some of these are genetic disorders as well. For the sake of time, I'm not touching those entities as such. I'm going to present you a set of distal renal tubular acidosis. Distal renal tubular acidosis could also be familial and can have some genetic basis. But there are some renal tubular acidosis which are secondary. With systemic diseases, some drugs can produce, and another important cause is low renal tract abnormalities. And this is pertinent to both pediatric nephrology and pediatric urology. The obstructive uropathy and vesico-uretary reflux. How I got interested in this area is that our pediatric endocrinologist, they used to send these patients to me who came with bony abnormalities, rickets, children, normal renal function. So they thought it's a renal bone disease. It is a renal bone disease in some way, but actually these patients had renal tubular acidosis. And to my surprise, many of them had, most of them had distal renal tubular acidosis. But mostly we think distal RTA would present with stones, nephrocalcinosis, but these children were presenting with low urinary tract abnormalities, quite a significant number of them, and bone involvement, and renal function was not very much impaired. The GFR was affected. So what we took these patients and then went into the detail. Many of these patients had posterior urethral valves. They had presented with growth retardation, rickets. Some of them had nephrocalcinosis, hypokalemia, polyuria, polydipsia, dehydration. So there was a significant problem. These were referred patients, I agree. It's not that if you go in general population of pediatrics, you will not find such large numbers. And they were on investigations found to have classical distal renal tubular acidosis with lower urinary tract abnormalities and vesico-uretary reflux. So we prospectively looked at these patients with posterior urethral valve and vesico-uretary reflux. These are the testing which we had used for the bladder dysfunction, cystometry, looked at the proteinuria. These children were managed by urologists for the vesico-urethric valve. The acidification tests were done, the bladder abnormalities were documented, and MCU and voiding cystograms, the VR grading, then the urodynamic studies. Then they went for the surgery. And like fulguration of valve is one standard. Some of them were also subjected to vesicostomy and fulguration. They were evaluated for distal RTA at the baseline and then every 3 months. And the urological follow-up and evaluation like cystometry was done at baseline and then at the last follow-up. And we tried to look at the age of presentation and at what age the surgery was done.
how long the children waited for the surgery after they presented, what were the grades of the vesico-ureteric reflux and the urodynamic abnormalities. As you can see, some of the children were 5 months old, some of them were older. The period they waited from presentation to the intervention, because of so many reasons, varied from 1 month to 80 months. Some of them on their own decided to delay, and some of them, the intervention was delayed because of other administrative factors. And after follow-up, they have been observed for around 2 years. So what we were looking at is what happened to the distal renal tubular acidosis after they were intervened, and also the other important thing is the proteinuria. Because one problem remains that many of these children, even after they were intervened, they continue to progress. And by the time they reach adulthood, many of them develop CKD, because they have proteinuria of different grades, which is also one of the important factors for progression of CKD. So they were subjected for urine protein measurements, and also these are the other manifestations like the metabolic bone disease, the stature and hypercalciuria, the urodynamic abnormalities of different types like detrusor instability, hypocontractile bladder, and the compliance of the bladder. What was very evident that the age of presentation, the age at which they were intervened surgically, and the period, the delay in the intervention, they were the three important factors besides the degree of urodynamic abnormalities. If they didn't have much of urodynamic abnormalities, they did much better. Much better in the sense of the proteinuria progression, and also the distal RTA, whether it continued and persisted. So this was seen even on follow-up. And by the statistical evaluation, age, as I told you, was very important. The delay was the other thing. And if they had more urodynamic derangements, the both distal RTA and the progression of the proteinuria is more likely to occur. So despite the intervention in terms of the posterior urethral wall or other abnormalities, many of these children continued to have distal renal tubular acidosis, and also the proteinuria, though it got reduced, but it persisted. And many of these patients, the proteinuria actually increased. The other important thing was that in patients who progressed, both in terms of their distal renal tubular acidic defects persisting and also the proteinuria, the urological dysfunction was also of the higher grade. So ultimately, these are the important factors of the age, the delay in intervention, and the degree of lower urinary tract urodynamic abnormalities which decide about the outcome in these children. The important thing we learned that in children with lower urinary tract abnormalities, we should look for distal renal tubular acidosis even if it is not very evident, because it will be seen in majority of patients, especially if they have high grade of urological or urodynamic abnormalities with the posterior urethral wall. Why? Because if you take care of it, you will be able to also take care of their bone disease. Secondly, distal RTA, though classically considered not so much associated with bone disease, but it is associated with bone disease. If you take care of this acidemia, which is mainly because of the distal renal tubular acidification defect, you will correct the bone disease, and also I feel it will have a positive effect in terms of retarding the progression of the chronic kidney disease and managing the systemic manifestation as such. The persistent distal RTA, though it may be an important contributor because acidosis is responsible for kidney disease progression, but it is a marker that the disease is persisting. So I think there is a complex interplay of tubular damage, the glomerular injury. At present, we have no definite interventions, at least in pediatric patients. In adults, besides the ACE inhibitors, but in adults, we have other two interventions like using Fineron or using the SGLT2 inhibitors, which could be very important in combining, but at present they are not cleared for pediatric use. So we are quite handicapped, but this is really giving us this experience that distal RTA should be looked for in these children. Some of them were very young, 4 to 5 months old, who present with bone disease and lower urinary tract abnormalities. Thank you very much.
Thank you. Thank you, sir. Considering your vast experience and knowledge, everything, I don't think that due to the quorum, I open the house for the question and any queries from the house.
Sir, during your times when there was no solution for this soda bica, because we have recently had a company come up with the solution. So what was the way you would replace the alkali in children for say 4-year or 5-year-old children who the soda bica tablets are quite big, difficult to swallow?
So like we were using the commercially available soda bica, which is used for IV. You can use it for oral also, but that's a little more expensive. Soda bicarb tablets or soda bicarb solution which is available now is quite cheap. But the very small children, it may not be easy to use tablets. I think solution is definitely, now it is available and we can use it very easily.
Right. Any questions from the house then we can take?
That we have been using during our everyday called soda bicarb and called calcium chloride. I think we are able to use is 2.5 grams. Okay.
So thank you very much.
Thank you. Oh, wonderful session.
We have a session on childhood UTI, the Newcastle model. For this session, may I invite Dr. Ratan Jha, Senior Consultant Nephrologist at Care Hospital, Hyderabad, Dr. Shravan Kumar, Senior Consultant Neonatologist at Patna, Dr. Madhu Sinha, who is a Senior Consultant Pediatrician as well as Secretary, Bihar Academy of Pediatrician, Indian Academy of Pediatrician, Bihar chapter, Dr. Pragya Pant. She is faculty and in charge of Department of Nephrology at Rajendra Institute of Medical Sciences, Ranchi, and Dr. Binay Ranjan, Consultant Pediatrician from Patna. May I request Chairperson to introduce the speaker.
Good evening, friends. It's a pleasure for me to introduce Vincent C., a delegate from UK, who is a consultant pediatric nephrologist, clinical director for quality and safety is his designation. Present affiliation is he is attached to Great North Children's Hospital, Newcastle. UK. He's consultant from 2019, that is roughly 5 years in that hospital. He's chair of many of the societies, has many research publications and many other affiliations and awards. I request Dr. Vincent C. to now talk about a very common topic of childhood UTI, the Newcastle model. What is there for us as even an adult nephrologist to learn about this model of care of common disease, the childhood UTI. Over to you, sir.
Great. Well, thank you very much for inviting me. I especially want to thank Rajiv Sinha, who's a great friend of mine. And actually, there's a slight typo there. I've been a consultant since 2009. Both Rajiv and I trained at Great Ormond Street together. And when we left, I went to Newcastle, and he came back to Calcutta. And we've been very good friends since. And we've done a lot of collaboration, and he's a fantastic guy. And I also want to thank Herman for inviting me. So actually, one question is, why am I here? I work in the northeast of England, and it's a delight to come to the northeast of India to be with you all. This is a regional meeting, and I'm actually extremely proud to be in a regional meeting because I'm the representative of the Royal College of Pediatrics and Child Health for the northeast, and it's so important to have regional meetings, especially with your adult colleagues. So that's delightful to be here. Also, I've learned recently that the Indian Society is changing your childhood UTI guideline. So maybe I can share some of my reflection, because we've changed over time as well, and it may be quite timely to do this. So this is where I work in the northeast, and in Newcastle, it's somewhere in the middle. But we influence the whole of the region in the guidelines that we've set. In Newcastle, we've been looking at UTIs for the last 20 plus years. My predecessor, Malcolm Coulthard, has published quite a lot on it, and really I'm just following in his footsteps. So imagine you have a child with a urine infection. One question is, after you treated him or her, do you screen for underlying abnormalities? And there's been a lot of debate recently about that. You have to consider what the risks of the tests are. And a few years ago, Rajiv did a randomized controlled trial, and even if you give antibiotic cover, 1.5% will get a UTI because of the VCUG. So actually, it's not risk-free. Then you get a result. What do you do with it? What if you get grade 1 reflux? Will you get grade 4 reflux? And will you actually reduce future complications with knowledge of the result now, or could you wait till you have more infection? And that's what I'll try to discuss. So this is what we used to do in Newcastle and the northeast of England, and actually in the whole of the UK until things have gradually changed. So imagine a 5-month-old girl not feeling very well, quickly improve. So in the UK, general practitioners will treat them, see them, but they'll send them to us to image afterwards. In the past, we'll do all the imaging, including a VCUG. We find a grade 2 reflux. What do we do with her? How long should we put her on prophylaxis? In the past, we may have put her for many years because we will test her to see if she's growing out the reflux. And if she doesn't, we'll just carry on antibiotics. Was that the right thing? What about a 10-year-old girl who keeps having urine infection and you image her and she has a small scar? You've done all you can, you've treated bad and bowel, you put in prophylaxis, still getting urine infections. What can you do? What about a newborn child? We used to do a lot of familial screening. When they're born, we'll put a catheter in, they've got reflux, what do you do? And what about a boy who's got Pseudomonas UTI? Is that a typical UTI? This is the NICE guideline. It came out 15 years ago. So Newcastle was the last to change, and we actually changed last year. And with the NICE guideline, essentially, if you have mild UTI, then you either don't image for your first UTI, or if you're less than 6 months old, you just do an ultrasound scan. So in Newcastle service, we were very aggressive with imaging in the past with antibiotic prophylaxis, but we changed last year, and I'll share with you some of the evidence why we think we had to change. So which guidelines right? And you're changing your guidelines soon. The problem with the reflux, how do you reduce recurrent urine infection sibling screening, we know 1 in 5 children, offsprings, will have reflux if you look for it. The result of moving is nice. And one question is, should we image even less the non-E. coli UTIs? Okay, so start off with the problem with reflux. So the prophylaxis antibiotics, and it was really nice to hear your talk about the history of nephrotic syndrome. Jean Smelly was a very famous nephrologist in London, Great Ormond Street, and she recognized that 50 years ago, if you have recurrent UTIs and you got referred to Great Ormond Street, there's high chance you find some untreated abnormality, a 10-year-old boy with valves. If you put them on low-dose antibiotics, miraculously a lot of urinary infections disappear. It was a retrospective cohort. So since then, there's been a movement to actually image children to make sure we don't miss any of these. But actually, times have changed as well. I think parents are less tolerant of recurrent urinary tract infections. Oh, sorry, my clock has reset, so do tell me if I'm running too late. So the RIVER study, you've all heard of this. This came about 5 years ago from the States. This is the best study that there has been in reflux. And it's a multi-center study. They took children, young children who've had a couple of UTIs, see whether they got reflux, and then randomized them. They were mainly girls. Huge study, 300 in each arm, prophylaxis or not. 2 years follow-up, and they found it really halves the amount of UTIs, on prophylaxis. But actually, even if the research nurses phoned the family, children were only taking prophylaxis, 75% of the med 75% of the times. Antibiotic prophylaxis really has a great place. It reduces symptomatic urine infections. But actually, when you look at the meta-analysis, it doesn't actually matter whether you got reflux or not. Even for children without reflux, it can reduce symptomatic urine infections. However, none of the meta-analysis show that it reduces scarring, and maybe you need a much greater population, but then the numbers needed to treat this will be so high. There are downsides for long-term prophylaxis. Increasingly, we recognize that if you are a very small child and you get lots of courses of antibiotics, there's a high chance of obesity. They have lesser response to vaccines for some reason, so it's something to do with their immune system, the microbiome. And this 40% antibiotic resistant, it may be that the other 60% just wasn't taking the antibiotics. You should be resistant to your prophylaxis if you're taking it. But this is a good take-home. This came from the RIVER study and the parallel QT study, when children who didn't have reflux were just observed over time. And what they found was that actually what causes scarring, what are the factors? Duration of being febrile. And it's not like 1 day versus 5 days versus 10 days. It's 1 day versus 2 days versus 3 days to 4 days. So it's like any other infection. We need to stamp on it quickly. What was associated with new scarring? Your ethnicity, you can't change that. Older children. Bladder and bowel dysfunction, huge a factor, and recurrent urinary tract infections. So I think we need to jump on children with recurrent urinary tract infections, especially febrile ones. What was not associated, though, was interesting as well. How rich or poor the parents were, whether the child had reflux or not, how high their temperature was, and whether they were on prophylaxis or not did not influence scarring. So, how do you reduce urine infection? Prophylaxis, one. But bowel and bladder dysfunction, we in our UTI clinic prescribe more laxatives than antibiotic prophylaxis. Constipation is very much related to incontinence and urinary tract infection. And on the right there in the Venn diagram, these were children who didn't end up on prophylaxis. And what it showed was that bowel and bladder dysfunction had a bigger effect than having reflux on whether you get recurrent urinary infection or not. And if you have both, you have a double whammy. And why does bladder and bowel dysfunction cause this recurrent infection? So the MRI scan, the brown bit is stool, and then the white bit is urine. And if you have lots of stool in the rectum, you don't empty your bladder very well. And this is very old data, but there's a clinic in Iowa in the States, which if you go there and they treat you really aggressively, everything gets better, wetting, nighttime wetting, and urine infections. If you've done everything, what we're doing now in Newcastle, and this is where the next talk comes in, maybe very interesting, is that we're using these PIC cystograms. So these are children who we've done everything for. We don't find reflux in traditional imaging, but the urologists now are putting a scope in the bladder and actually directly trying to induce, putting a dye in to look for occult reflux. And they're finding about 90% of reflux, so they put a scope near the ureteric orifices. And if they find reflux, they'll do some deflux or anti-reflux procedure. And 84% of children in this small pilot study were off antibiotics within 2 years. So maybe something we should think about. Okay, so what about newborn screening? We used to do this because we were really worried about children developing UTIs if we're not looking for reflux and treating early. So there's some truth from studies since people started doing it. We know that most children, even if they've got a reflux, will never have a urine infection if you find out at birth. Even if you have high-grade reflux, majority of reflux will resolve, and the red line is grade 3 to 5 reflux. They also, many will resolve. In Boston's Children's, they used to do newborn screening, and they actually did not find that it reduces urine infection. They actually found that if they screened them and found they got UTI, they had more UTIs, maybe more awareness. Siblings who never have urine infection were screened. Some of them had abnormal DMSAs on birth. They've never had a urine infection. So this concept of dysplasia is there. And some of these didn't have reflux. And the most important thing is it's very expensive. To prevent one urine infection, you have to screen lots of children, and it costs lots and lots of money. And the more philosophical question is reflux actually normal, a part of growing up in normal children? You know, you only know that if you do MCGs on normal children, and you think actually no one ever do that, it's not very, research ethical. But actually someone did in 1967 in Germany. They actually went to their children's wards, found children who came in with a headache or something, and asked the parents if they want to participate. And look, you have the same graph as you have on the children who were screened after urine infection. In Scandinavia, in Finland, people used to do a lot of screening after urine infection, but actually recently they took all their data and classified the children whether they had a definite urine infection and those which are less and less likely, and children who they probably never had a urine infection. And look, the reflux rate was exactly the same. So maybe reflux isn't associated with urine infection in the babies. And so we looked at our own data for sibling screening if they had normal antenatal screening. And we found that our pickup rate for high-grade reflux was only 5%. Another 10% were low-grade reflux. One question was actually, if we can we use ultrasound scan to choose the ones that are more likely to have reflux and do MCGs only on those? But look, these were the ones with high-grade reflux. The box shows the one with abnormal scans. So it didn't really correlate very well, so it wasn't a particularly good idea. So actually, we've stopped doing newborn screening, and no one else in the country were doing them either. So we've moved to NICE because of these new evidence in the last 10 years. Previously, we had very high antibiotic use because a lot of children had put on antibiotics while waiting for the scans. And we did an antibiotic first approach rather than bladder bowel approach first. And we got this data, and these were children less than 5 years old prescribed one of these antibiotics for recurrent urinary tract infection, for prophylaxis. And we were a big outlier because everyone else had moved to NICE. So if you move to NICE, you can reduce antibiotic prescription quite significantly. And our colleagues at Middlesbrough did some modeling data for us, 100 children who got admitted with UTIs and what would have happened if you went to NICE. You would halve the number of ultrasound scans you do, reduce by to a third number of DMSAs, and then reduce to a quarter number of MCUGs. And look, our pickup rate was so low anyway, and we actually picked up nearly all of them the first time. So we've changed since Easter last year, and we're doing much less imaging. So one question is, we've had 20 years of data of UTIs in our service, and our service mainly takes children from primary care. And I want to challenge you whether we should actually image non-E. coli UTIs. When you look at the literature, I found 13, I suspect, well, 15 papers where they actually, most of them said actually non-E. coli UTI did have a high pickup rate in imaging. But look, they were nearly all tertiary centers, like what most of us work in. And the recurrent UTI rate was quite high in some of these studies. So we looked at our own data. We had nearly 8,000 children over 20 years, less than 12 years of age, had a first urine infection, but these were children who were not ill enough to be admitted to hospital. And we actually found less abnormality. So E. coli had about 9%, Enterococcus 5%, Capsulitis proteus pseudomonas 5%. So maybe for children who were not admitted to hospital, were not septic, who had non-E. coli UTI, it may not be necessary. Okay, so take homes. VUR may not be pathological unless your child is getting recurrent urinary tract infections. I think it's really important to treat febrile UTIs early, and that's days, not like weeks, and minimize recurrent urine infections to reduce scarring. Treat bladder and bowel very well. Prophylaxis can be very helpful, and we need a pathway to urology. Newborn familial screening is very difficult to justify, and ultrasound scan is not useful to risk stratify. And I think in the UK, if a non-E. coli UTI who were treated outside the hospital, we probably don't need to do too much imaging for. So moving to NICE was quite sensible for our healthcare system. Question is it sensible for you? Should all countries image less? Well, I think it very much depends on prevalence. You know, are you working in primary care or tertiary care? And what interventions do you have? Because actually, Rajiv and colleagues in Calcutta looked at their first UTIs in infants. And we looked at our first UTIs in infants. Look, in Calcutta, 30% pickup rate for ultrasound and DMSA, we were only picking up 5%. But the VCUG were about the same. And the UK NICE guideline is not applicable for many other countries because it's written for a whole healthcare service. And importantly, they had cost considerations to minimize the economic costs. So I'll leave you to ponder that, and I hope it's been useful. Great. Questions? Did I stick to the time?
Quite interesting from an adult perspective that we said that what you said, three things. VUR in a normal child is normal. That is what you said. One point that is a message to be given?
Well, I think if you have urine infections, if you have one urine infection and you never have another one, having VUR probably doesn't matter. But if you are having febrile recurrent urine infection, yeah, VUR is important. You can do something about it.
One of the interesting treating points that you said that febrile UTI has to be treated early to prevent scars.
Correct.
Is it so?
Yes, so that's what the literature tells us. So really, the darker line is risk of getting new scarring over 2 years, and how long you wait before starting effective antibiotics. And it's not days and days, it's actually a small number of days. 1 day is better than 2 days, better than 3 days.
And regarding the investigation that you said, it is not worth doing as a routine for siblings, just based on the data that you presented.
Correct, yeah. So in the past, and I don't know what your practice is, but in the past we were asking, babies when they were born, asking families, oh, do you have reflux yourself, or your other children have reflux? And if they did, we will stick a catheter in them.
For such a nice model of Newcastle's. And I want to know that you are saying that infection, and whatever infection we should treat immediately. And but asymptomatic bacteria is also may cause scar in renal. So what is your idea about the asymptomatic bacteria?
Well, I mean, I think firstly, one question is, how do you know that they have asymptomatic bacteria? So you have to take a urine. Yeah, so if they haven't got symptoms, I wouldn't take a urine sample.
You are saying that imaging is not important and treatment is important. So how long we should give, and what is your idea we should know?
Yeah, I mean, really, I think what I'm trying to say is that you may not need to image so quick. You may not need to jump to imaging after the first urine infection. You may, unless they're very young. But if you have a 2-year-old who have a first urine infection and it's quite mild, from our data in our country, there's no great need to be too aggressive with imaging. But if you're having multiple infections, then yes, imaging is very important. Or if you get a UTI that's so severe, very difficult to treat, imaging is very important.
You mentioned that imaging may not be necessary. First time, your own chief used to say BUR is not a benign condition.
Sorry?
I'm quoting Dr. Coulthard. He said BUR is not a benign condition. When you say imaging, does it mean only ultrasonography or the MCUG and everything? I would probably recommend any suspected UTI to have a good ultrasound. If that is normal, you can probably wait.
Yes, so in our NICE guidelines in the UK, if you're less than 6 months and you have any urine infection, you'll get an ultrasound scan. If you're over 6 months, but it's very mild and it's your first or second urine infection, or they're very infrequent, then we would not image now, just because the pickup rate is so low. And also, when you have a result, you're unlikely to action it.
Dr. Bani.
A question, Vincent, here.
Hello.
Thanks for raising some very interesting points. I think you were wondering in your last slide whether all the NICE guidelines are appropriate for the Indian scenario. There are some differences between UK and India. I think follow-up of patients right from the antenatal period to subsequent, later stages does not occur under the same healthcare system in India. So many children in India presenting with a UTI we would not have access to the antenatal scans. Many children presenting to me with the first UTI may have taken antibiotics, over-the-counter antibiotics for a fever 1 year ago without a urine test. So this kind of longitudinal follow-up, we do not have access to quite often. And therefore, I think I would really support what Dr. Srivastava was trying to say, that in our country, at least a good ultrasound is essential, because sometimes people miss something like posterior urethral valves presenting with UTI. spinal abnormalities, gross, voiding abnormalities, where you would get some clue from a good history and from a ultrasound. So that is, I think,
Yes,
a good ultrasound, even in the first UTI, I think is
yes,
vital.
you're absolutely correct. Because so people sometimes criticize NICE guideline for, for not picking up everything. But you're absolutely right, because it very much depends on what your healthcare setup is. In the UK, if you don't come to clinic, for example, if you don't come to my pediatric clinic twice, the social services will come to your door and knock on your door and say, why have you not come to clinic? So it's a very different system. And I think your guideline needs to reflect what your healthcare system is.
I think you have very impressive follow-up and record keeping. But what we have to understand that if you have a guideline which has been made for NHS, they need to be followed. And what you have said, that one of the important guiding principle for these guidelines is the cost cutting. In India, the problem is that if the child comes and we say that VUR is innocuous, and the parents are demanding to have something to be done, and if you miss it, if you don't do it, there is nothing which is going to come to our help, because we will be questioned, why didn't you get a simple ultrasound done? So what the point you are making is very important, that guidelines have to be specific to the type of setup we are having, and especially in our situation where the medical treatment is actually on demand. I can go directly to any institution and anybody and can take treatment, while in NHS you have to go from one step to another, and you have a very tight system functioning which is controlling the cost also, in which even if you may get an appointment after 1 year, nobody is going to question the clinician.
Yes.
Because that is as per the guideline and as per the system. So here we have to be more careful. So I would not consider VUR as a totally innocuous thing, because we have seen these patients, one, they present late, second, they have been intervened, they look fine. But they continue to deteriorate over a period of time.
And look at this. So this is first UTIs in infants less than 12 months. Your pickup rate for DMSA abnormality is already 27%. Ours is only 3%. So that is such a big difference. So your guideline needs to be very different from ours. Absolutely. Excellent point.
Excuse me. Good evening, sir. Presentation. I mean, there are so many confusions which I am having as a pediatrician. So I think from Indian context, somebody from Indian faculty, they should give a clear-cut guideline on this platform that number one, that below 1 year, if you get UTI documented with urine routine and urine culture with a history of fever, then what all imaging should be done or not done, what age, and for how long antibiotic prophylaxis. I think just a protocol based, I think from ma'am or someone from Indian context. So the imaging, the age, and antibiotic prophylaxis, just in summer.
So a couple of points. One is that, before I go to the Indian guideline, one is that VUR is a controversial thing. And it is always a chicken and an egg. Whether VUR causes the damage or whether the damage was there already before the VUR happened, we will never know. And this controversy will go on. I completely agree that we need a guideline. And there is a very clear guideline at the moment by the Indian Society of Pediatric Nephrology guideline. It was published in 2011, where they say that below 1 year, all UTI should be investigated. Above 1 year, if the ultrasound is abnormal or a DMSA is abnormal or there is any features of atypical UTI, should be investigated. That guideline will be updated very soon. We are becoming slightly more nicer. But I think it will be updated in about a month or two, it will be published. But till now,
Like below 1 year, all those 3 imaging, you have to get it done.
At the moment, that's what I also.
Right.
So this was a discussion to sort of generate interest and for all of us to appreciate the lot of uncertainties that there in the viewer management. As Dr.
But if in like less 6 months, if you get a viewer and if you get grade 3, grade 4, then definitely the intervention should also be there.
What intervention?
I mean, that only I'm asking for from your side.
Prophylactic antibiotic.
To
There
give the
is
antibiotic.
prophylactic antibiotic.
Prophylactic antibiotic.
Low dose antibiotics
Yes.
should be continued for 3 years.
Choice
For
of
the-
antibiotics,
for the
sir?
grade 3 and above, low dose antibiotics should be continued till the child is potty trained. At
Till
least.
the child is?
Is potty trained at least. Toilet trained.
Okay.
Around 2 years.
Okay.
And what antibiotic? Less than 6 months, Sporidex. After 6 months, maybe cotrimoxazole. So not Sporidex means cephalexin.
Cephalexin and then cotrimoxazole.
I don't get anything from Sporidex.
Yes, yes.
And
Understood.
more than that,
Understood.
cotrimoxazole.
Fine, thank you.
I'm very sorry,
May I ask you
confused
something?
all of you.
I mean,
Yes.
Yeah. So basically, from a surgeon's perspective, we have been, for the last 3 decades, we have completely changed our outlook on reflux. Maybe 3 decades back, we used to operate on more than 60% of our cases of high-grade reflux, and maybe now it has come down to 10%. So we are also more into conservative treatment for VUR. Now, I have one question. Like, we had a concept that many of these children, and in fact, all those studies were published from UK, that many of the girls, especially with high-grade reflux, but no recurrent UTI, who were kept unoperated, unintervened, non-intervened, go on to develop pyelonephritis during their pregnancy. So that was a compelling point, asking the surgeons to get a definitive treatment for the high-grade reflux in girls, even if they were asymptomatic, and even if it was diagnosed beyond 5 years. So any update regarding this?
Yeah, that's an interesting point. I mean, perhaps you should invite me back in a year's time, and then I can look at the literature about that, because I wonder whether a lot of what was said in the past is what people's personal experiences, rather than really rooted in the literature. And because you need really good records to get something like that. So pass.
So, to conclude, few points which I have understood after the discussion from all the colleagues, that patients who are below 1 year of age who are having UTI has to be investigated. It cannot be left like that. Ultrasound followed by maybe a DMSA scan, and whether to go for VCUG or not is a personal choice. But beyond 1 year, probably we can be a bit liberal unless the person has recurrent UTI. But ultrasound will be a basic test that has to be done in all patients, followed by DMSA. Regarding the antibiotic prophylaxis, below 1 year, what I understood, at least has to be given for 1 year or till they become toilet trained. And beyond 1 year, this will be a personal choice to go for 1 year or beyond. If there are any other contradiction to my understanding, my teacher, Dr. Sharma is there, Dr. Srivastav is there to at least highlight this point, how long to give antibiotic prophylaxis, and whether to do all the 3 tests in case we decide to go for an investigation.
That if somebody has a VUR alone, or somebody has a VUR with other bladder abnormalities and dysfunction, that is also very crucial. Sometimes in children it could be missed. So I personally would have high index of suspicion in a child who is less than 6 months or less than 1 year. Even as the guidelines, the Indian pediatric nephrology, even more than 1 year, they are indirectly suggesting ultrasound and DMSA scan, because these are non-invasive investigations and not very expensive if the patient can afford. The prophylaxis will depend at least 1 or 2 years of prophylaxis, but if somebody is having recurrent UTI, the prophylaxis has to be much longer.
Can I?
I think ultrasonography is all right. I think probably any child should be having it, UTI. DMSA I would very much hesitate to do, or MCUG even much more, uncommonly.
Can I add one point? I think what hopefully my talk has stimulated the debate, but I think the important take home is that you got, with all the research that you guys have presented earlier, you guys are doing so amazingly, in your research output, that maybe all the previous research done in the UK, US, they're very specific to the healthcare system. And you may be able to create research in your own healthcare system to justify, to actually see what your changes will do.
All toilet changed babies with recurrent UTI, can we rule out the bowel bladder dysfunction, and how? Toilet trained babies with recurrent UTI, how will we approach for the bowel bladder dysfunction, which is a very important finding for the recurrent UTI in toilet trained babies?
So I couldn't hear very, but I think your question was, how do you find out about the bowel and bladder dysfunction? Is that correct? Yeah, so bowel and bladder dysfunction is best. So we have a nurse-led service who use charts. They ask the family to document everything. Just because if you ask the family, "Are you constipated?" they'll always say no. But if you go into it in real detail, then you might get a very different answer.
Thank you, Dr. Vincent, for this wonderful presentation. I think we should wrap up this session now.
So it's a panel discussion. The topic for this panel discussion is pediatric bladder disorders, a crosstalk between pediatric nephrologist and pediatric urologist. And for this session, it's my privilege to call upon Professor Rajesh Kumar Tiwari, who is Head of Department of Urology at Indira Gandhi Institute of Medical Sciences, Patna. May I request Dr. Professor Tiwari to introduce the moderator.
The lower urinary tract, the lower bladder and the sphincters, if they are not behaving properly, their dysfunction can cause not only impaired quality of life, that is incontinence, but they can also lead to silent damage to the kidneys. So to identify the abnormal voiding dysfunction in the children is very important. And for that, this session is devoted to the discussion on bladder dysfunction, and we have got a moderator, Dr. Subhasis Saha. He will moderate the panel discussion, and Dr. Subhasis Saha is a consultant pediatric surgeon at Amri Hospital, Kolkata. He has got 25 years of clinical experience in the field of pediatric urology. His areas of interest are posterior through wall, neurogenic bladder, hypospadias. He has chaired many societies. He was the chairman of the Society for Pediatric Urology, editorial secretary, Journal of Indian Association of Pediatric Surgeons, and he has many publications, national and international, to his credit. So I invite Dr. Subhasis Saha to moderate the session.
Thank you, sir. Thank you, sir. So first of all, the organizers, especially Professor Hemant Kumar and the entire team, for inviting us and extending an unparalleled hospitality. So I am the odd man out in this entire crowd, being a surgeon. But as the caption says, a crosstalk between pediatric urology and the pediatric nephrology. So I think this background has helped me a lot in my entire career. So I was very lucky, I was very fortunate to have the support of pediatric nephrologists from the beginning of my career. And many of my children bear fruit to that. And I think they have done pretty well due to the support of the nephrologists. So I would like to welcome Professor Himesh, Professor Orpita, Professor Shumantro, Dr. Jayati, and for this panel today, Dr. Jayati Sengupta. Dr. Jayati Sengupta is Consultant Department of Pediatric Nephrology in the Department of Pediatrics, AMRI Hospital, Kolkata. Her experience is 25 years. Her areas of interest are nephrotic syndrome, UTI, enuresis, and bladder disorders. She has several chapters in the textbooks and several publications in peer-reviewed national journal. So I would next like to invite Dr. Himesh Bormon. He's a professor and head of the department. Dr. Himesh, of Pediatrics, Northeastern Regional Institute of Medical Sciences, Shillong. So his areas of interest are pediatric nephrology and medical education and quality improvement. He's a life member of IAP, ISPN, and many other organizations, and is a president of IAP Meghalaya State Branch. I would like to invite Dr. Orpita Gogoi. She's an assistant professor, Department of Pediatrics, Assam Medical College, Dibrugarh. And Dr. Sumantro Raut. He's an assistant professor, North Bengal Medical College, Darjeeling. His main areas of interest are cystinosis, peritoneal dialysis, and he also has a lot of publications. So without going into much details, so today the system in the next 30 minutes we are going to do is we'll discuss a few cases. And basically, we would like to impress upon you the role of various investigations, history taking, clinical examinations, and how we can actually very simple disorders. It's very important for the proper diagnosis to go in details into all these things. So basically, it will not be it will be very simple discussion, but we would like to highlight certain points. So firstly, I would ask Dr. Himesh to just enlighten the audience. What are the armamentarium in the hands of pediatric nephrologists and neurologists to diagnose any disorder?
So it's not different from any other disorder. We have your history taking, examination, and some tests that are required. And for history taking, it's very important so that we can define what is the problem. So what is the frequency? Is there any incontinence? What is the bowel pattern? Is there any holding maneuver? And these all we need to take in more detail. And then an extension of history taking is a bowel and bladder diary. That is very important. I think we'll be talking about that in next few slides. And then in clinical examination, we need to examine for any stigmata of your spinal problem, like examining the back is very important for any neurocutaneous markers, examining from cremasteric reflexes, anal tone, strength of the lower limb, especially the grasping power of toes, which corresponds to the your sacral levels. So these are important. Palpating for any lump. So all these are very important. And imaging, like we have X-rays, ultrasound, MRI, CECT, Euroflow, and Eurodynamics are again some things that we can do.
Yeah, now here I would like to stress upon this simple investigation called uroflowmetry. Now, urodynamic study involves putting a catheter in the urethra, but uroflowmetry can actually be done in the OPD basis. And if you add EMG electrodes to the patient, to the child, and he or she just voids, this just an uroflowmetry can give you a host of informations, and sometimes it's as good as a urodynamic study. So that's a very basic investigation, but is often neglected. So the first case, we'll discuss 4 or 5 patients. Now this is a common scenario. Many of your, in many of your chambers you get patients. This is a boy with a 9-year-old boy with a genital pain and increased frequency. So basically, this is the main complaints are the pain at the tip of the penis, on and off, especially during voiding. And this is a very short duration, lasts 2-3 weeks. So it's more during the evening. There is no history of dysuria. Apparently, there is no history of constipation according to parents. This is very important. And there is increased frequency of urine. So I would like to ask Dr. Orpita, what would you think about this case and how would you just proceed?
Yes, sir. So this child presented with complaints of penile tip pain along with increased frequency without any dysuria. So per se this looks like a urinary tract infection. Right. So we would do the general examination followed by a focused local examination of the genitalia, which was essentially normal. The prepuce was unremarkable and it was retractable. The ultrasound KUB turned out to be normal, but the finding here which was important was a rectal diameter of 40 millimeters. The transrectal diameter cutoff is 38 millimeters for children with a high sensitivity and specificity. So we definitely see that there is rectal dilatation here. However, on history, the parents categorically denied that there was a history of constipation. They said that the child used to pass stool every day, once every day. After this, we did an X-ray abdomen, and this is the X-ray abdomen which is showing a loaded colon and a loaded rectum. So this is definitely a constipation which was there. This needs to be addressed by removing the fecolates first by giving bowel washes, and then we need to give long-term laxatives to this child, which will improve his symptoms. So this was done. Stool softeners were started after evacuation, and the pain in fact disappeared after some days. However, the increase in the frequency of urine persisted.
So, I mean, at this point of time, I mean, basically, many of these children who are habitually, chronically constipated, the parents will come and tell that there is no constipation, the child is passing urine daily. So the point is, it's not that he's passing stool daily or not daily, but important is the amount and the frequency. So basically, it might, so it's a fraction of evacuation of the entire rectal load. So in these cases, there are two very simple maneuvers. One is an ultrasound. So you can ask your sonologist when he is doing an ultrasound of the kidney and bladder just to add the transverse rectal diameter. It's a very simple maneuver to note whether the constipation is present or not. And once in a while, to convince the parents, you might as well go for a single abdominal X-ray, because that will show the entire colon is loaded with stool. And these constipation patients will never improve with just laxatives. Plain polyethylene glycol will never solve these problems unless these patients are disimpacted properly. And that disimpaction also includes a search for an anal fissure, which might need treatment, because as you all know, whenever there is an anal fissure, there is a spasm of the sphincter. So the laxatives won't work. So you need to work upon the fissure, you need to work upon proper evacuation of the colon, and then only the laxatives are going to work in the long term. So here we find that the pain completely disappeared just by disimpacting the colon and putting him on laxatives. But the increased frequency persisted. Parents coming to the OPD and saying that he is passing urine 30 times, 40 times. So what are you going to do now? What's the next step? Yeah, please. Exactly. Per rectum. Exactly. So this is a very important point, because per rectal examination is something which is a taboo for many of the physicians. So I think this is a very simple maneuver, and I think all clinicians should not hesitate to do a per rectal examination. That actually tells you on your face that the child is constipated. It's a very, very important point. So, Orpita, would you just...
So now we also looked at the bladder diary which the child was maintaining, and it showed that the amount of intake was as high as 6.5 liters per day, 6 to 6.5, and the output was around 5.3 liters per day. So was this a polyuria in fact, because that is what the bladder diary looks like. However, on further historical examination, it was found that the child was being asked to drink lots of water in order to maintain kidney health. So he was being forced to take excessive water, and that was probably the reason for the polyuria.
So basically, I mean, this is a simple case. The moment the intake was reduced, this all polyuria, etc., everything went away. So the point is, this is a simple, bladder diary is a very simple tool. You don't need any fancy investigation, nothing. You can just ask the parents to maintain a proper chart of the intake and output. That will tell you give you a lot of information. It will give you an information about what is the capacity of the bladder, unstimulated capacity of the bladder, whether there is an incontinence, whether there is any strain, what is the interval, what is the duration when he is peeing the most, and whether it is at all related to the intake or not. So bladder diary gives you a treasure of information, and it's a very simple thing to maintain. So you should make a habit of going through the bladder diary before you go for other higher investigation, more invasive investigation.
What was the urine report, urine examination?
Urine examination, there was no urine culture, didn't show any growth, and the pH, etc. was fine. Specific gravity was...
What I'm trying to say is that the first test will be the urine examination.
I mean,
because
that I think I had
somebody
mentioned.
is constipated, that's fine.
So
you have to rule out whether
Yeah,
there's any UTI.
yeah, of course. In the first visit, urine routine and culture was done, and which was normal. And this child didn't have any phimosis or any
The
other
child did
differential.
not have any fever.
Yeah.
The child was febrile, firstly, and
Still,
there was, yeah.
no,
but
he's correct.
still,
I mean,
yes,
any
yeah.
frequency
Still you
we should
can have a
always
lower,
rule out
you can have a cystitis.
bacteriuria.
Also, we urologists are always asked whether it is daytime frequency or nighttime frequency.
Yeah, right.
If it is daytime frequency only, then it is behavioral mainly.
Yeah.
If it is nighttime frequency as well, then we can look for the pathology.
Yeah. So now this is an 8-year-old female child. The first episode of UTI was as early as 6 months, and then the child had been having recurrent episodes of febrile UTI. So there is a history of constipation going back since 2 years of age. So when we took a detailed history, the urinary frequency was normal, but there was severe urgency and urge incontinence. Often the child could not control, and there was severe pain. She had to run to the toilet. There was dampness of underpants, and the need to change underpants almost 5 to 6 times a day. And there is a sense of incomplete voiding, and immediately after voiding, she used to dribble, and the child sat to void again and complete the rest of the void. That was the pattern. There was mild hesitancy, and there was both diurnal as well as nocturnal enuresis. So I would ask Dr. Sumontro, how would you go ahead, plan?
Okay. First of all, good evening to my all colleagues from Patna. So regarding this lower urinary tract symptoms, actually ICCS has clearly defined 6-7 symptoms which are of different lower tract etiology. So either they have specific cutoff point after which they are maybe below which they are physiological and after which they are mostly pathological. Suppose for example a straining or a poor stream is pathological since day 1 of life. So there are such cutoffs in ICCS guideline also. So here the child, some lower urinary tract symptoms are suggestive of overactive bladder, just like a increased urgency or urgency leak, and some symptoms are classical for underactive bladder, just like straining. So here the child's behave with some abnormal behavior. So after completing the proper history, and as sir told, after a proper examinations of the genital, of the spine, back, after searching for renomegaly, renal angle tenderness, and abdomen fecoris palpation, we can, and the blood pressure, obviously, blood pressure and height. So then we can move away to our simple investigations. The investigations other than our routine urine test and maybe a RFT, we can proceed to the next investigation, that may be some imaging. We will start with the imaging of some non-radiation imaging. Ultrasound is the key investigation for that one. But we need preferably a detailed renometry, where everything just like a hydronephrosis, the epidiameter, the cortical thickness, hydroureter, particularly post-void residue, and that needs a patience for the sonologist, because child may not pee in a single attempt whenever he is in ultrasound lab. So maybe 2-3 attempts may be needed for the child to be comfortable. And after this whole ultrasound, suppose this child in ultrasound shows some there's a picture, sir, in the next page, I think. Yeah. So
no, that ultrasound is not, right, because ultrasound was
next page, I think there. Anyhow, so in this case, after the ultrasound, we have the next, whenever there is bilateral hydroureter nephrosis, our next line of management is probably a radiation investigation, that is an MCUG, at least for our part of India. So we did an MCUG for this child, and this MCUG is supposed to be bilateral grade 4 or grade 5 view vesico-uretary reflux with a more or less normal looking bladder and a normal looking urethra as per we will see it. So that can be a case of maybe a primary viewer, but we don't have a control film here, but seems to be a background constipation or the bowel shadows which has been visible. So regarding this bilateral viewer, is there any kidney permanent scarring or not, that we can see in a later radiation, that is a DMSA scan. So we have a next picture of DMSA scan also, I think.
Yeah.
And here DMSA, here right side is the right one. So right kidney is showing some lower pole permanent cold area, cold spot, and maybe some cold spots in the upper pole also. So maybe right side kidney is showing some permanent scar, possibly. And then this is the ultrasound, what I am just telling, that we need to check each point of the renometry, and among them we can see the bladder volume, which was as per the expected volume capacity. The post-void residue is still present after 2-3 attempts of the child. So there is a high PVR. So it carries a significance till a 8-year-old child currently who is having a high PVR with a bilateral hydroureter with a bilateral high-grade reflux with scar on one kidney. So we need to suggest, is there any anatomical defect or just only a functional defect that we need to address?
Now, another thing is very important is encopresis. That means constipation is something. And if you continually have a pant soiled with stool, this is overflow. So basically encopresis is a direct indicator from history that this child is constipated and is completely retaining stool. So there you should start the treatment with proper enema and proper washout. So this was a partial voiding diary, which is actually incomplete. Yeah.
Yes, sir. So as sir already told us, sir, the basic investigation and the key factor is this good proper diary, maybe of consecutive or non-consecutive 3 days at least. Here we need to mention every point that is better done in holidays when all the parents' cooperation is also needed. How many voids are there, each amount of void on each time, how much there is a incontinence or leak or accident, and how is the stool frequency also. Parallelly we can see it, the timing also. Here though there is not a complete diary, but at least we can realize the girl is 8 years, so the expected bladder capacity is around 10 ounce. That means around 300 ml. So at least 75 to 80% of the expected bladder capacity should be there. Here most of the voids are 30 to 60 ml, so they are too much less voiding in a more frequent manner. So here, and so small frequent void. So next step what we can do, either preferably we can go for a non-invasive test because the toilet trained child, we can go for a uroflow, and as sir told that if you can attach some electrodes in the urethral sphincter or in the at least in the pelvic area, so we can get an EMG along with uroflow.
So basically in such cases we first treat the bowel and then follow up for a couple of weeks. If the symptoms still persist, then we go for higher investigations, including a uroflow. And this is a little higher thing, that's an urodynamic study. I mean, now urodynamic study is not something very fancy or very rocket science. So we do urodynamic study in investigation evaluation even in small infants also. I mean, that's not a big deal. And the child is as comfortable because here the child lies in the mother's lap, a very small child. Or they are comfortable. They can sit. They can relax in the room. There are videos and there are play toys and everything to make them relaxed. So here, if you can just say the salient points.
Okay. So as I told, UDS we are not directly jumping to UDS properly unless the child is having some known neurological defect, some known meningomyelocele operated, maybe a post-operative case of PUV or any other CACUD. Otherwise, for this type of dysfunctional voiding suspected, we can always try a good bladder training, a good bowel training for at least 2 to 3 months. And even if the symptoms are not getting corrected after that proper training, then we can jump to either a uroflow or a urodynamic study. And here we can see the pink color line is actually the flow pattern. And the flow pattern is occurring in 3 or 4 bouts. So there are multiple bouts of void which is not touching the baseline, probably a staccato type of void that can suggest that there is a good pressure during voiding, but there are multiple time of obstruction. So this is a classical case maybe of DST, that is a detrusor sphincter dyssynergia can be possible. So again,
this is basically another child with a 4-year female with dysfunctional voiding. Now here the child used to post void, there was a dribble in every time. And here we find something interesting. I mean, would you like to highlight? You can.
So in this child, as MCU starts with the control film, we can again see some of the bowel gas shadows are there. Bladder in full dilatation looks wall more or less okay. And during voiding, there is no gross view or is been located in the epifilm. In the lateral oblique film, the urethra seems more or less okay. But as it is a girl child, in the 5th picture, the middle of the lower picture, we can see some amount of dye has been accumulated in the vaginal area. So that can be a case of vaginal void, which is again a common thing in today's era where most of the parents are working parents and we give less amount of time for our child's bowel habit or the bladder habit, how to sit properly in a potty. That is a difficult thing to get trained to a child. So unfortunately, many of the child don't have a good potty training and good bladder training, and they can capture the urine in their vagina and cause a vaginal void, which can subsequently causes multiple time leaks and can get infected also. So we have a next picture, we have a proper training picture also. So for this child, what we can suggest to treat the constipation effectively at least for 4 to 6 months or maybe more than that. And as there is no other MCU abnormality, the vaginal void can be easily treated with proper urinary habits to wide apart the leg while sitting in a proper toilet. Either it is a western type of toilet, or if the child is little bit less age, they can use any type of potty seat like a horse potty where the legs are wide apart and they can fully pee on that period.
So I mean, that's very important to show the mom how to just separate this thing. The child needs to be trained properly. Now this is the uroflowmetry of the same child. It shows a sort of tower-shaped curve, and all these things can be. So the average flow rate is much more, 27.5 here. You can see. So these are all cases of frequency of urine, but each has a different story behind. So this is another extraordinary high daytime frequency, another child. This is a 4-year-old male child with severe increased daytime frequency for the last 3 months. Now child has urgency and can sense the urine. So informs before passing urine. There is no incontinence, no nighttime symptoms. Passes stool daily, no constipation at all, and good amount of stool. He had a similar episode 1 year ago, but went to some local GP and there was no urotherapy given. The child settled of its own. Now the child complains of poor urinary flow, bad flow. Now poor urinary flow per se can have two connotations. Either it could be some obstruction or it could be poor muscular activity. So these are the two broad connotations from a poor urinary flow. Ultrasound is absolutely normal. So, Dr. Jayati, would you just
yeah, so we have this child who is otherwise quite well, in the sense that he's passing there's just increased frequency of urine, and mainly in the daytime, so there are no problems at night, firstly. Secondly, there is no incontinence. So he knows that he wants to pee, he just goes and pees, but he is never wetting his pants. So these are two very important things which will tell us that probably we are not dealing with something very organic. Probably we are dealing with something more functional. And first thing is obviously to see whether these children are constipated. This is a very common reason. Constipation is a very common reason why this happens, because the loaded rectum presses on the urethra, and they gives it rise to this feeling of urgency.
Here there is no constipation. Here
there is no constiption.
And this is a 4-year child, so we are expecting a capacity of 150 ml.
Exactly. Now, so when we do the avoiding diary, we find that with the child is passing, is a huge increased frequency. Normal frequency in a child of this age should be around 6 to 8 times in a day, and this is more than I think 20 times. So, but there is no nocturnal enuresis. So the first thing in this child would be to do a proper ultrasound, and to see, first thing would be a routine urine, obviously, to rule out anything, to see whether, often these children have worms also, so those are small, simple things which we need to rule out. The next thing, which is very common, is psychogenic causes. Any problem in the family, any examinations going on, or any disruptions in the household things. So these have to be ruled out. If these are also normal, and ultrasound obviously has to be done, first to see if there is a very low capacity bladder which is making him pee so small amounts, or there is an obstruction or increased post-void volume for which he is going and peeing very frequently. So if the ultrasound shows a normal bladder, no PVR, normal volume bladder, that there is no praviculation, the bladder wall is not thickened, the transrectal diameter is normal. So if you have all these things, so then we can more or less establish that probably this child is having a functional bladder disorder, which is very common in children nowadays, which is known as what we call as pollakiuria, in which is very common in boys. They have these episodic increased frequencies for a few months, and with a lot of distraction, sometimes biofeedbacks, they slowly settle down. But some of them do not, and if it is a persistent problem, then we may need to go for a uroflowmetry. So now, if worst case scenario, probably even a urodynamics if it is not responding. Now, in this case, we did a uroflowmetry, and we can see that it is a very staccato curve. Normally, in a uroflowmetry, we are supposed to have a bell-shaped curve in which the Qmax, or the maximum voided volume, happens within the first 5 to 8 seconds, and then it follows a bell-shaped curve. Now, whenever you have a staccato curve, we know that there is a kind of a straining. So there's a kind of an overactive bladder, and the bladder is trying to force against either a urethra which is dysnergic. So the bladder, the detrusor is contracting, but probably the urethral sphincter is not relaxing. So these patients then need to be taken up for further investigation and further management.
So this VCUG is actually normal. I mean, this child had a normal obstructed
Yes.
uroflowmetry, normal VCUG, normal cystometry. There is
Yeah.
no.
So we can see the voiding cystometry that there is a lot of we can see the diffuser pressure. The pressures have not increased.
On the baseline.
Yeah, at the baseline the pressures
normal
are fine.
compliance.
Yeah, but there's a lot of contraction of the abdominal muscle. So he's basically trying to voluntarily generate some pressure. So very common is constipation in these patients, which can happen. And biofeedback things for these children are very important. If you give them this idea of voluntarily relaxation and contraction of bladder, if you can teach them, so they really do improve. But if still they don't, then sometimes a small trial of oxybutynin may be helpful if the frequency is really bad.
So I would now just briefly brush about what are the issues in neurogenic bladder which we need to be aware of. I would request Dr. Orpita to highlight what are the points you want to know and why a neurogenic bladder is a matter of concern to all the pediatricians.
So neurogenic bladder is basically alteration in the nerve supply of the bladder and the colorectal apparatus, which may, in children mostly it is due to spinal dystrophisms and spina bifida. The bladder disorders which may happen along with in a neurogenic bladder could be ranging from bladder overactivity, loss of compliance of the bladder, or in some cases lack of sphincter tone or myogenic failure, out of which overactivity is more common, and that leads to back pressure changes. Along with that, there may be some post-void residue, and it may predispose to higher tract affection of the higher tract. Thirdly, there is also a mechanical overdistension of the rectum due to poor anal tone, and this may indirectly impact upon the on the bladder and compromise the bladder function. And this compromised bladder function ultimately leads to renal damage, and they may end up in CKD. The point here to remember for us is that most of these neurogenic bladders, as they are detected quite early in life due to the spinal dystrophism, they are operated, but sometimes they are lost to follow up. So what we should instill in them is that a CIC should be, regular CIC should be started early on, and it should be continued. So how does CIC help? CIC basically removes the post-void residue so that prevents the urine from staying in the bladder for too long and leading to urinary tract infections. At the same time, the overactivity of the bladder, which is quite common, that is taken care of by decompressing the bladder frequently. So these are the things which are there in a neurogenic bladder.
So basically, even in 2023, we find that many of our colleagues, I mean, even after the neurosurgeons operate on a myelomeningocele and the parents are not counseled about the issues of bladder and bowel. They come to us at 5 years, 6 years with raised creatinine. This is the unfortunate part. So basically, on the part of the pediatricians, one should be very much aware and start counseling the parents from day one that operation is fine, surgery is fine, but these children will lead to, because all of them are born with normal kidneys. So it's our responsibility to see that the renal function is preserved.
I think we should just emphasize that nobody goes home without learning how to do a CIC after myelomeningocele surgery. Secondly, I think an urodynamic should be done, as is the practice and the recommendation, as soon as we can, to see basically what is the filling pressure, because not everybody is going to go into a neurogenic bladder probably, but if it's a safe bladder, we know the filling pressures is okay, the storage pressure is not very high, there is the bladder bowel, the bladder and the sphincter coordination is more or less okay, so these patients we can know will not do too badly and can be followed up better. So I think safety is very important.
Yeah, due to lack of time, we are just skipping through the last few slides. So basically, this is a graph showing, this is something we call loss of compliance. Because you can see this is a neurogenic bladder patient who had been operated twice within the age of 3 months. And actually, she presented to us with all these issues. Passing urine in small amounts, continually passing urine, passing stool every 5 to 6 days. So both the bladder and bowel are affected. So here, I mean, this is...
I think, the dribbling, sometimes we have to tell them that dribbling is probably a safety mechanism. If the bladder, if the sphincter is open and the urine dribbles out, probably it will prevent the pressures from going into the kidney and cause damage. So just doing an unnecessary surgery by controlling the incontinence or tightening the sphincter probably is not the answer. So I think that should be, the nephrologist should be just aware of
Dr.
that.
Sumanth, you can highlight what are the things in this study in a short, in 2 seconds.
It's basically a high capacity bladder, and that's too having significant provoked spontaneous, as per the EMG record shows there are some detrusor pressure intermittently. So though there is no leak properly, so this is very atypical case actually, sir. We rarely find this type of case, maybe for post-neurogenic case only. And as I already told, for neurogenic bladder, we need to go for a early UDS, no matter, because our center, Subhash sir, is doing UDS in case of infant also. So for this type of patient, we need to do a early UDS to know what exact management do we need. Do we need a bladder neck relaxer? Do we need a anticholinergic to increase the bladder volume, or do we need separate some entity of bladder biofeedback techniques? Next slide, sir.
This is basically a very unsafe bladder because parents are happy, there is no leakage. Child is not leaking, child is not smelling of urine. But we are absolutely unhappy because high pressure is going on and the child is not leaking. That causes damage to the kidneys. A child who is continually leaking of urine, the kidneys are safe. So this is after we started oxybutynin. Any changes you find?
Okay. Now here the spontaneous high pressure has been reduced. That was initially more than, actually people say more than 20 pressure is not safe one. And that can cause the upper tract damage. So here the pressure has a little bit dropped down from the earlier one. And then here what we fear of giving oxybutynin or tropan, that the bladder becomes more residual volumes, and also there is an increase of constipation. But anyway, these neurogenic bladder child are on CIC, so we are not fearful for a residual volume of urine, and also they are on regular bowel wash, so we are not fearful for the constipation also. So we can safely give the tropan and do the regular CIC, that is clean intermittent catheterization, and a regular bowel wash.
So this is last case. Basically, we are happy when the PUV patients, they are having normal creatinine, voiding well, no incontinence, no residual urine. We are extremely happy. Now this is one of our such patients whom we had operated in infancy. We had done a check cystoscopy after 6 months, and then again at 5 years. He has been absolutely well after that. Now at 14 years, the only complaint is occasional dampness of pants. Now all these children, now we are going for follow-up and urodynamic study at adolescence. Now what is happening, you see? So I would request Dr. Orpita, can you just highlight what are these things here?
We can see that there is increased amount of frequency of urination. It's more than 10 times, I think, and the amounts which are passed are also more. So frequency is high, and void volumes are high with 24-hour output of around 2.2 to 3 liters with urgency. The stars which are seen, those are indicative of urgency.
So here, Dr. Jayati, would you highlight? This is the ultrasound.
Yeah, so any child with PUV, we have to remember that just surgery, doing the surgery is not the end of the story, it's just the beginning of the story. So this child is going to be the child who has been under pressure, the kidneys have been under pressure for so long, often have irrepressible changes in the kidneys. And the most important thing is the bladder. These bladders, even if they are relieved, they still are less compliant bladders. They have problems in the output, and there will be some kind of overactivity in this. So the ultrasound, if the ultrasound shows, I think, can I just see the ultrasound once? Yes. So the pelvic, the APD is increased. We can see though the wall thickness of the bladder is just within normal limit, but the child is having a lot of post-void urine. So, and if you see the uroflowmetry, you can see that it's a plateau kind of a curve. So that means the child is trying to pee against the pressure. It is not being able to pee out. So there is against the kind of obstruction is persistent.
So basically, we find a huge residual urine, bilateral upper tract dilatation, yes, and a staccato flow, interrupted flow. Now here we did a video UDS, which is showing absolutely pressure at baseline. There is no loss of compliance, nothing, yes, and there is no reflux, and a nice contour of the bladder. So what is wrong? Because the child apparently was wrong. Good, apparently was absolutely well. So this is the voiding study. Now voiding study, you can see there is a good amount of pressure being generated by...
lot of pressure, the bladder is not very compliant. So the child is peeing against a lot of pressure.
Bladder is absolutely compliant because this is a filling curve. Filling curve is on the baseline.
Okay, sorry.
This is a voiding curve.
Oh, this is a voiding curve. Yeah, sorry. So this is a very high pressure. I mean, the pressure is is going up till I think 36.
So the idea of presenting this case was all these sort of patients were included in myogenic failure. That was our classical teaching during 10, 20 years back, that the PUV patient goes from hyperreflexia ultimately to myogenic failure in the adolescence.
So
but is there anything that is beyond our vision? So this patient, is it myogenic failure? I mean,
so these patients will, at some point of time, they can become, the bladder pressure can become underactive and then go into myogenic failure.
No,
so
that's
I
a different story.
That is what we have to.
We don't want to highlight that. We want to highlight that a huge residual urine, very poor flow and interrupted flow apparently was considered by us as myogenic failure. But this simple investigation, urodynamic study, shows us that enough of muscle force is there. Detrusor is absolutely active. So this is a voiding image.
Yes, but the flow is still very poor. Still the child is, not the amount of flow is still coming a little less than what it should be.
Dr. Shumanto, would you just enlighten?